yes. So we'll start now. Myself, Dr. Sunil Ingre, Secretary IMA Pune. Uh, Very good morning and a warm welcome to all the delegates at. Hello.
Continue, Manas.
Okay. Okay. A warm welcome to all the faculties and delegates. Actually, today's program was designed to be a physical CME in Sancheti Hall at IMA with felicitation of eminent doctors on the eve of Doctors' Day for their outstanding contribution towards the field of medicine. But due to this new lockdown norms, we had to convert this into a webinar. Friends, lot has been changed due to this COVID in our life, and so is the medical legal scenario. Uh, we are making more and more use of technology due to this COVID. We have lot many problems like shortage of oxygen, medicines, and intolerant groups of society, which has added to our problems in this medical legal scenario. Our medical legal team at IMA Pune has designed a very beautiful program for today to discuss about what has changed in the medical legal scenario during COVID. I request our President Dr. B.L. Deshmukh sir to say a few words at the beginning.
Thank you, Sunil. Good morning, everyone. I welcome you all for this webinar on medical legal scenario during COVID-19. We have eminent faculties on this subject, that like negligence, tackle attacks on doctors, new amendments of different laws like CPA, MTP, epidemic laws, tackling and prevent the COVID emergencies, concept of documentation and landmark judgment. With this word, I will stop here and hand over mic to proceeding for this
Yes.
further.
Today's first talk is about concepts of negligence during COVID. We have Dr. Naurange sir to enlighten about this. I request my co-secretary, Dr. Alka Shirsagar madam, to introduce Dr. Jain Naurange sir. Come in. Fast.
Good morning, all. I'm Dr. Alka Shirsagar, Secretary IMA Pune. Dr. Naurange, I think he doesn't need any introduction because he's well known to Pune, Maharashtra, and India and all over. He has got gold medals at MBBS, DCH, and MD, and 4th year LLB. Sir is an honorary pediatrician at Srivatsa Sasun Jazal Hospitals, Bhartiya Samaj Seva Kendra, Dinanath Hospital, and Sayadri Hospitals. Sir was a past president, IMA Pune, IIP Pune, and IIP Maharashtra. Vice Chairman, Medicolegal, IMA headquarters, held 2,340 doctors so far. Designed and conducted first medical legal course for IMA. Visiting faculty, ILS Law College, Pune. Competitive 26 marathon, half and full, and cycling. Donated blood about 60 times. Recipient of Bertha Holt International Award for Rehabilitation of more than 10,000 family deprived children in last 40 years in USA 2002. Recipient of Best India Doctor Award by Indian Medical Association 2015. This award was installed in 2015 only. He is the chairman of IMA MS Social Security Scheme from 2018 till now. So over to Dr. Jayan Naurange sir.
Thank you, Alka madam, for a very lucid introduction. And we will straightway proceed to the first talk of mine. Usually, this is the first talk in all such seminars because we have to be very clear about what we are supposed to do, what we are usually caught about, and how to take care of those points so that we can minimize the number of litigations, the amount of litigation time we have to spend, and prevention is always better than cure, as we always say. But added to that, prevention is not only better than cure, it is much cheaper than cure, and it is more certain though you cannot 100% say that I will be never asked to face the litigation. That is not possible in a democratic society. We can definitely minimize it, and if at all the litigation goes in and we have to face the consequences of such a litigation, it will be minimally hazardous. And number two, 99.9% you will escape out of the clutches of these unnecessary problems, and many times it will be withdrawn ultimately by the complainant if we follow certain principles. I'm very happy to say that we have crossed the magic figure of 100, that is 3-digit figure, and without wasting time, I start sharing my screen. So just hold on for a moment till we start with the slide presentations. At the outset, I'm very happy to say, and we welcome Dr. Shivkumar Kumbare from Dharwad. He is always there with IMA Pune's most of the programs, in particular all medical legal programs, as well as the Maharashtra State medical legal programs. And you will always see that whatever lacuna is there in our presentations which will be covered and capped by Dr. Kumbare. So you will always get the wisdom of pearls of wisdom from him through his vast experience. So my topic today is medical negligence during the COVID era 2019 or COVID-19 era. In the beginning, I would say the basic principles remain the same. Basic foundation of the subject remains the same. And we will proceed on the same lines what we are usually covering about medical negligence, but added every now and then the flow chart is there. There is a different set of newer and newer principles, and what has changed in the COVID era, I will explain to you in last 3 or 4 slides, but the basic principles of medical negligence will remain the same. In the beginning, I salute all of you. It is only because of the developments in the respective fields that more and more complicated and lengthy procedures, surgeries, and other treatments are possible with good patient safety and very good outcomes. But this has increased our legal vulnerability. Why? Because the expectations have skyrocketed. Expectations of a complete cure or at least complete relief have skyrocketed with the minimally invasive procedures. There are many responsibilities added to the doctor's field, and that is not only to treat but checking the consent, blood and medicine. So these are sort of semi-administrative and administrative requirements of a good doctor. And identification of the person, invasive procedures have increased, and anesthesia is also quite complicated. So these all complicate the matter. Usually the outcome is very good, safer and complete, but then once it is not there, and because the costs involved are pretty high, the litigation chances are more. COVID-19 has tested our limits of endurance also, limits of resilience, and temporarily, at least, I am using the word temporarily into bracket, earned the public gratitude. How it translates into medical legal cases, it will be the time which will decide. 2 important ethical principles. There are 4 main, but 2 are very important. And if we follow those ethical principles, the chances are that you will not be hauled up by any legal forums for medical negligence. Number 1, do not do any harm. If you can't treat, if you cannot cure, if you cannot relieve, at least don't add any harm by way of your treatment and management. So that is number 1. Second is eternal vigilance. So this word is mine, but what it says is patient autonomy and confidentiality. So we have to be eternally vigilant. We cannot say that I have treated so many thousands of patients, I have got such an experience, I have got such a vast knowledge, and you just neglect the basic temperature, pulse, respiration of the patient. That is not pardonable, and this is where usually the mistakes are occurring. So eternal vigilance throughout your career is the most important thing. Third thing is patient autonomy. So forget the old days have gone, that I tell the paternalistic approach. So don't get confused about the words. I tell the patient, you follow this, and he has to just mutely follow it. Those days are gone. It is patient autonomy, means patient is a part of the patient himself, his own care. And that means we have to give all the information and pros and cons of a particular thing. And then he has to decide whether he wants to follow or whether he wants to go away from treatment. So you cannot force anything. There cannot be any dictation. So that is what is patient autonomy, and that is very rather difficult, or I would say becoming more difficult for us to follow those older generation doctors. But even the younger generation doctors are trained by these older generation seniors, and there the paternalistic approach is there, that whether you understand or I understand, you are sitting on that side of the chair, and therefore you have to listen to me. Those are gone. It is only that you give all the information and pros and cons of a particular management, and it is up to the patient to say yes, no, or he may say I will postpone this thing. Don't worry about that. You have to respect the patient's autonomy. And next point is confidence. So in short, patient is a partner in his own management. And next is confidentiality. Don't leak the confidentiality. And here is a problem for COVID-19 patients when we are treating the patients with telemedicine. I will come to that a little later. We are answerable to various forums, and number one is medical council, like State Medical Council and MCI, that is Medical Council of India, and that is now converted or renamed as National Medical Council. So MCI is no more there, but it is NMC. But the rules have remained the same. Criminal courts, that's all the police procedure, magistrates and sessions courts and high courts and Supreme Courts, etc. But criminal justice system. Next is civil courts, but usually no patient goes to the civil courts because they don't get the justice unless their grandchild is born. Consumer forums, so there is a tremendous delay over there. Consumer forums is a specialized variety of civil courts, and consumer forums is no more the term forum is applicable. It should be called now as consumer commissions. I have changed many of the slides, but one or two slides have remained, that as per the new amended Consumer Act of 2019, the forum has been now changed, nomenclature is changed to commission. Otherwise, everything has remained the same. Regulatory bodies like corporation, the municipal corporations, tax authorities, MPCB, that is the Pollution Control Board, BN is Bombay Nursing Home Registration Act or Clinical Establishment Act, where this is not available. So in Maharashtra it is not applicable as yet. Human Rights Commission, Right to Information Act, specific laws like MTP, PCP, NDT and POXO Act. Then comes the authorities like municipal authorities, government authorities, in particularly COVID-19 era or any epidemic act. Even it occurred in the swine flu era in 2009. And now there are audits. And yesterday only, most of the hospitals have received notification from corporation that all patients' bills and papers will be audited, even if there is no complaint, right, in a retrospective manner from April 2021. So we are, of course, going to resist this, but this is how it is occurring. Media, there is no control over media. So this part, I will leave it gray, and how to tackle it, we'll see if there is any question. So media includes the social media like Facebook, WhatsApp, etc. And last is, the worst is Janata Darbar. Of course, it does not have legal sanctity, but this is the one which is most dreaded forum where we have to face sometimes, and that is the point of violence. And these are the special category of patients where you have to have very careful and very considered approach. I would say give consideration and care to all patients, but more so be very careful when the patient is basically a lawyer or a pleader. Number two, press, that is journalists or the media people, police and authorities, they try to excessively use their authority. Even if he is a simple havaldar, they would come to the hospital and interfere with the billing, interfere with the actually management of the patient, and such 3 complaints we have already done to the Police Commissioner of Pune. So actions are being taken, but they don't issue a generalized statement. That is where the problem lies. Politicians, they can be of help, but more than that, majoritarily they can create a nuisance, and smaller the politician, more is the it is something like urethral stone or ureteric stone. Smaller the stone, more pain it causes because it moves. So same way, it is the junior most or lower cadre politician who creates more problems. Physicians, that means be very careful about fellow physicians as patients, because they expect too much. They read halfway through in the electronic media like Google, and they themselves can become worse patients than ordinary patients. Patients in general also are all potential litigants, and in particularly COVID-19 patients, because it's a very, very unpredictable disease. If somebody asks me what is the specialty of COVID, I would say it is the most unpredictable disease with most unpredictable management and most unpredictable outcomes. Next is NRIs and NRI doctor relatives sitting there across 7 seas, and they go on giving some wrong advice without taking into consideration or without talking to the local doctor here. Now, why the problem has come up now with increasing litigation? Because I thought of some of the reasons, and these are Indian economy has gone global. All, including the doctors, will face greater and newer challenges, and the natural fallout of this is aggressive consumerism, explosive media, cutthroat. That means who gives the first news without verification whether it's a true news or wrong news, who gives this news first on the TV. So that is how the explosive media is there, and they make the simple things also most prominent and bold. Cutthroat and unfair competition amongst ourselves, increasing costs of even production of a doctor, making of a doctor, and also any management. More modern the treatment, more expensive it is. Information explosion, I am saying information explosion and not as knowledge explosion, because what you get on internet is information and not knowledge. But this has caused terribly increased expectations from patients. So every patient going to the hospital must get cured, as if nobody should die. This cannot be a reality, and that is why where the friction comes. Increase in success rate of litigants from, it used to be 2% 4 years back, and now it is 34%, and that too of a very high compensation amounts. So increasing success for litigants, whether right or wrong, it is up to the judiciary to say, but they will have to introspect what is going wrong. Loose comments by our colleagues, false claims by our competitors, online registration of complaints with MNC and CPA. Now the new CPA of 2019 says that you can register a complaint even online and even at the complainant's place. Supposing I am a super specialist, patient has come to me from Patna or even Assam, he can lodge a complaint against me in Assam, which was not the case with the previous law, and this is bound to create huge problems to defend your case in Assam and Patna. The answer for this is why. First of all, answer for this is learning today, listening to today's talk very carefully. And number two is the vibrant doctor-patient relationship. Let's have patience. Let's imbibe patience in the patient's mind, persistence of our activities, persistence in sound standard ethical practices, good communication, and communication is single most important preventive factor, and eternal vigilance. Let's be gentle, upright, pure-hearted. Also explain that information, knowledge, and wisdom are not the same. And one more thing, ask about the history of allergy, which is missing in many medical legal cases I am seeing. Ask the history of anticoagulants, in particular aspirin, warfarin, etc. Or even these days there is a new, there are several many drugs where patients are kept on anticoagulants for various reasons, and so many patients of COVID beyond the age of 35 are right now on anticoagulants as a preventive measure or as a treatment measure. So ask this history before any procedure or any medication, any chronic medication. So the best question is, are you on any chronic medication? But you have to ask in a very simple language, are you taking medicines for more than 1 month? And that is a chronic medication. If you say chronic medication and just hypothetically say that they are aware of what is meant by chronic and acute, that's not the case. So this is my favorite slide, and you can make a copy of this. And this is for prevention of allegation. And in short, this is in a nutshell the total topic today. So prevention of medical negligence, I am saying prevention of allegations and not a guarantee that there would not be any allegations. A stands for attention. So attend the patient very carefully, give attention to the patient's symptoms and signs, and whatever he is saying, ask about. So basic dictum remains the same. Second is additional opinion in time. Whenever patients progress in the hospital or in the clinic is not according to what you expect. Behavior, B stands for behavior and bills, and check the COVID-19 compatible behavior at the clinic as well as during teleconsultation. So this is a new thing. That means when you are giving advice to the patient, even at the clinic on teleconsultation, whether you are following all the advice you are giving to the patient, that means using the gloves, using the mask or double mask, then using the face shield, and whether you are keeping the distance, whether you have kept the outside bottle for hand sanitization, that everything is going to matter. Now when I'm saying teleconsultation, for example, I'm talking to you and I'm not wearing the mask, but then in teleconsultation, I should be properly dressed. I should not be in a very casual dress and taking the things very casually. I'm attending my home and taking tea on one side and asking the patient and eating something and listening in a haphazard way. These are bad mannerisms. So in teleconsultation, we have to be very careful that we have to act in the mannerism of a professional. I think these are the things which should not be forgotten. Otherwise, at least make the your video temporarily closed when you're drinking tea, something like that. So be very careful about teleconsultation from your residence or clinic, what you are wearing, how you are behaving, and so on and so forth. C stands for communication, the most important aspect. Consent, and these are separate topics by themselves of whole 1 hour lectures. So soon I suppose we will be coming out with the medico legal certificate course once again. In that, these will be all covered in 1 hour's lecture topics. Denial to be documented is equally important. The consent or denial has to be after counseling, and you have to document that counseling. Compassion, no doctor can be a good doctor without good compassion. D stands for documents, and these are indeed your friends or foes, and that is in case of medical legal crisis. E stands for efficacy, expertise, empathy, and equipment. And F and G stand for good faith, and this is specifically defined in section 52 of Indian Penal Code, that nothing is said to be done in good faith unless the person possesses the proper prerequisite. That means for our condition, for doctors, it has to be proper degree and proper updated qualification, registration. So if it is not there, it is whatever you are doing, and if the case goes in the courts, it will be one of the first pitfalls that you have not got the updated registration. And I stands for insurance, and I would say indemnity insurance of at least 40 lakhs to 1 crore is required today, and ID proof. So ID proof of the patient is a must today. And this is, we are coming to the subject proper of Dr. Modi's textbook, that is want of, what is meant by negligence is want of reasonable degree of care or skill or willful negligence on the part of the doctor in treating a patient with whom there is an established doctor-patient relationship. Professional attendance is established so as to lead to bodily injury, or each word is important. Added to that definition way back when, of course, Professor Modi is no more there, but Dr. Parikh is carrying on that good activity of Dr. Modi's textbook. And now it is added that damage to the person's reputation, emotion, mental condition, work, or damage to the property. Everything is an injury or inclusive of negligence. Now, I would just skip a few slides because of shortage of time, and I will elaborate upon this particular definition so that everything is explained to you. Deficiency means, so word deficiency is more and more used after the Consumer Act came in picture, because it has defined the word deficiency and it is a little larger, wider than the word negligence. But by and large, in 95% of the cases, it is the courts would look at your negligence only, and there is a strict definition which I told you, and I will elaborate upon that. But deficiency means any fault, imperfection, shortcoming, or inadequacy in quality, nature, or manner of performance which is required or undertaken by a patient, by a person, by contact. By a person means by us, we are the service providers, or otherwise in relation to any service. So do not claim the services which you cannot provide. So don't say 24 hours medical services, I will keep my diagnostic center 24 hours open, if you can't do it. Next is deficiency has wider application than negligence. Now coming to medical negligence, and I will just explain this by bifurcating or quadrifurcating this definition, is that medical negligence can be civil or criminal. That is for us to understand, but basically negligence is negligence. So what is it? There are three elements to this. Number one is easy to understand, that there should be an established doctor-patient professional relationship. So what is meant by that? I will explain here only so that I can skip many slides. Doctor-patient relationship is said to be established, and that is what Professor Modi's definition also has mentioned, that patient has to come to you voluntarily by knowing about you through the publicity through mouth or publicity through lips. or publicity by just putting up a board and the patient gets attracted. Somebody tells you about, somebody tells him about your credentials. So that is what is meant by voluntariness on the part of the patient. So he comes voluntary to you. So where is it compulsory? It is compulsory during pre-employment examination, LIC examination, or when a classical example I will give, that there is an duty of every doctor that he gives a primary treatment for any roadside accident victim as per 1989 Supreme Court directive. So if a patient and your place of work is very near to an accident place, the patient will be brought to you. He is brought to you and you are given treatment compulsorily. That does not mean that this is a voluntary doctor-patient relationship and it is not established. So established doctor-patient relationship means it is not out of compulsion, but it is out of obligation, out of voluntariness. So whenever this established doctor-patient relationship is not there, the patient, you can always escape. Then we come to the point number 3. That means resultant damage. Whatever the patient is saying that injury has occurred, damage has occurred to him, has to have a nexus between the alleged act of negligence and the resultant damage. It cannot be too remote in time. This is very common in gynec practice, that patients are operated for tubectomy in 1999 and the patient complains of headache in the year 2021. Is there any connection? No. Or I will give a nearer example still more. If a patient has undergone laparotomy, or even for that matter, I take again the same example of tubal ligation or even cesarean or even any intestinal obstruction, and the patient lands up in adhesions after 20 years, 15 years, 10 years, there is no nexus between the two. Yes, there is nexus, but it is too remote in time. It cannot be alleged that it is because of the negligent act. So this is what I mean. So the classical example over here is one doctor, world famous Dr. Srikhande had a case against him of left foreign body following laparotomic surgery, or I think cholecystectomy, and the patient was a nurse, she claimed damages after 20 years. So she got symptoms after 10, 12 years and so on and so forth. And how can it be related to that? So this was denied by Supreme Court. So cases can occur, but you will escape. And then so these two things are easy to understand. And then we come to the second point, which is more important to get explained. And that means what is meant by gross negligence and what is meant by subtle negligence. Now here I will explain that gross negligence is something also described as res ipsa loquitur, means the facts of the case themselves speak for the act of negligence. There is no further proof required. For example, leaving sponge in the abdomen during abdominal surgery, leaving forceps inside, leaving scissors inside is taken as gross negligence, or amputating the right limb instead of the left limb, doing a tonsillectomy instead of tooth removal under GA in a child. So they are using, so there can be so many examples. Not checking the anesthesia equipment before giving general anesthesia. So these are, or not doing the test dose before giving penicillin. These are the cases of rare res ipsa loquitur or significant or gross negligence. And the other way, act of omission or commission, is very subtle. It is up to the courts to decide. It is up to the expert committees to say whether there is negligence or not. And the classical examples of this would be, another example of res ipsa today would be doing total mastectomy for any lump in breast without doing any biopsy or any attempt to do a final diagnosis before of a carcinoma before doing total mastectomy. So this is a gross example of gross negligence. Act of omission or commission, where there could be multiple views, or it could be that in this particular case I would have used these sorts of act of commission or omission. In a case of bronchial asthma, and you are giving old generation beta blockers like propranolol for associated hypertension, is not acceptable. But is it a gross negligence? No. There could be some compelling situations like myocardial infarction and hypertension, and also bronchial asthma, where you would use beta blockers even today. So whether it is an act of omission or commission will be decided by expert committees, the peers in the area, and as well as by the courts. So this is where the act of omission and commission are two sides of the same coin. Again, how I explain act of omission or commission as two sides of the same coin, giving another example. Today, I assume that all my gynecologist colleagues will admit, accept that standard indication for a planned cesarean, one of the indications is a primi case presenting with breach, full term primi presenting with breach. It's a standard indication to do a planned cesarean section. If a gynecologist says that I will deliver you taking all chances by vaginal delivery, maybe because there is an element of competition to attract the patient, and she does the vaginal delivery, there becomes obstructed head of the child, damage occurs to the baby or to the maternal birth parts or both, it's an act of commission. Something which other doctors would not venture to do, this gynecologist has done. So it's a negligence, act of commission. But if you see what she has omitted to do, she has omitted to do a cesarean section. So actually two sides of the same coin. It is only from understanding point of view that these are labeled as act of omission or act of commission. Now coming to another important concept, that who is to prove that the doctor was negligent? It is the patient who has to prove that the doctor was negligent. He or she cannot say that they did not know about the medical knowledge. They can take expert opinions from other colleague doctors or from textbook, or today internet is there. So onus of proof is on the patient. As far as usual negligence is concerned, but in few cases it reverts to doctor, and these are the situations like this: anesthetists, intensivists, surgeons, operation theaters, because there is no free access to the patient and they don't know, they are not allowed to have the graphics also. So over there, the primary responsibility of proving that you are non-negligent and you are diligent, you have taken all the due care, rests completely on the doctor and the hospital. So except barring aside these three situations, the entire gimmick of onus of proof is on the patient, and many cases are won on this point also. Now one more point, I'm coming in here only. This is, I think, turned out to be the most important slide to understand. Insurance covers only civil liability. So indemnity insurance, what I talked about, 40 lakhs to 2 crores, all that cover is for covering of your damages, compensations. It does not cover criminal liability. So this is another important thing to be understood. So I will take up one more slide, and this is important to understand. Doctor, how much? 5 minutes more?
5 minutes more.
Yeah. So final test of how the courts are not experts in the medical field, and they are not supposed to be experts in all the fields, because they are tackling all the fields. They are tackling from aircraft falling accidents to medical cases to insurance cases, company cases. So they are not supposed to be experts in all the fields. So what principle they use is that they would rely on the evidence laid down on the basis of an expert committee, or you have to lay down the evidence of your own colleague experts. And this is what is the golden test is Bolam's test. There is an evolution of the concept of medical negligence. Bolam's test was laid down in 1956-57 in UK, and which mentions that comparison is done, I'm telling you in simpler words, is done with a professional of average prudence, means average intelligence, average care, what ought to have been done or what ought not to have been done in a particular situation, similar situation, with reference to the contemporary thinking. See, the courts take a long time before the case comes for hearing. Patient might have lodged a complaint in 2015. Today is 2021 when the first hearing is occurring. So court cannot apply the standards of science today for a case in 2015. That is what I mean by a contemporary thinking of the given era. It should be in line with the majority of members in the profession. So whatever IMA members are saying, whatever the expert committee is saying, whatever the majority of the doctors in that particular subspecialty are saying, will be checked by the courts. And if the doctor has not fallen short of those standards, he will be exonerated. So over there, the Bolam's test was primarily implied for the treatment part, whether the treatment given is as per the standards followed by the majority in the profession. But things are changing today, and I come straightway to 2017, where there is, of course, there are many multiple decisions in between, and where it says that only to treatment is not there, the doctor has to be in conformity with the other professionals as far as the diagnosis, informed consent, investigations, and then the management and aftercare and the advice given. All things, the same principle will apply, that is comparison. So here we cannot make fault in any of these. See, please, I will repeat it again because it is not in the slide. Right from patient examination, history taking, informed consent taking, standard of care, pre-operative, post-operative investigations, or pre-operative or pre-management investigations, to current thinking, then the management, and what treatment is given after the patient's treatment is complete, advice is given. That is how the things have gone out. But then we have to remember one principle, that your actions and inactions will be checked with the others in the group, others of the peer, and then the comes. So far it was the expert opinion. Now it is the Bolito principle which is getting more and more followed, and that means that it is ultimately the court which has to decide whether negligence has occurred or not, and it is not completely relying on expert opinion. So just to rush through the slides, and this is criminal or civil, they are entirely two different things to understand, but basically it is the administration which is quite different. In here, the police is one of the parties, whereas civil side, it is usually the two private parties. Of course, government can be a party. Insurance is not possible in the criminal side, whereas insurance cover is there for the civil side. There is no period of limitation for criminal negligence, whereas period of limitations is limited to 2 to 3 years for civil and consumer side. And aim of criminal justice is deterrent and punitive, whereas it is aim is only compensation, and therefore it can be covered by insurance, and so on and so forth. So classification I already covered. Res ipsa loquitur, this gross negligence, subtle negligence, contributory negligence means patient doesn't listen to your advice, but the advice has to be proved. Advice has to be written advice, and therefore I would request you to mention the advice in writing on the discharge paper, as well as whatever follow-up papers you are giving, that you have to come on such and such date, follow this, come with the investigations, etc. Write down. Otherwise, it is not possible, and so on and so forth. Doctor, should I stop here? Can I continue for?
Yeah, you can continue for.
So this essential part I already covered. Now coming to one of the important judgments which is quoted right from 1969 till today is Dr. L.B. Joshi versus Dr. Trimbak Bapu Gorbole, which is this. Dr. Joshi is the founder of Joshi Hospital, which is there at Eranvana. And over there, he lost the case, but the three duties laid down by Supreme Court in that particular judgment is a person who holds himself ready to give medical advice, that means a qualified doctor, and treatment impliedly undertakes that he possesses the necessary skill. That means he has the required degree from a recognized university and knowledge for the purpose, so that is endorsed by registration. Such a person owes his patients three duties. Number one, a duty of care in deciding whether he will undertake the case. So you have a freedom to reject a case in the beginning. So you can refuse the treatment of a case, acceptance of the patient, and ordinarily we don't do that. But this is not, the exception here is medical emergencies. You have to treat emergency. I can't say that lady is delivering and I'm not going to attend because I'm a pediatrician. That is not possible. If there is no one else, you have to assist and call for a doctor's, gynecologist's help. So that is what I mean by medical emergency. A duty of care in deciding the line of treatment. So that is, you have to diagnose, investigate and treat. And third is a duty of administering that particular treatment. What the law requires is care and not cure. So law also understands that every case cannot be cured, but what is required is standard of care in that contemporary era by the fellow professionals they are giving. So I will skip all these intermediates because I already explained enough. Come to straightway slide number 34. I don't know how to come to slide number 34 straightway. It's taking time. जरा याच्यात जमत नाही ते. One more principle is that of vicarious liability. I think everybody should know about it. Whatever is done by your agents, that means employees, subordinates, contractors, employees, which result, that means your nurses, ayas, and which result, or even your locums, which result in injury to the patient, becomes the liability of the doctor, employing the doctor. And this principle underlying this legal principle is respondent superior. So the classical example here is Harjot Singh Ahluwalia versus Spring Meadows Hospital, where a 4-year-old child was getting treated for typhoid fever in 1994 or so in Delhi. And this was the 4th day of his treatment. Chloramphenicol was going on. The doctors were enjoying Ramayana serial at their home at 9:30 in the morning. The usual practice in private sector is whenever the drug prescribed is over, that means it is finished, the nurse would prescribe again the same thing, and the patient will bring the medicine from the nearby medical store, and instead of writing chloramphenicol, she wrote chloroquine. Chloroquine was purchased from the downstairs medical shop, and this was injected in a hurry through IV tubing. So chloroquine was given, the child became instantly brain dead. The child is still surviving, and this is brain dead patients are worst. So here the compensation, that time highest compensation was awarded against the doctors, against the hospital, which they were not directly involved because it was the nurse who had given the injection. But then the responsibility of the nurse comes on the principal employer. And therefore the principle of vicarious liability is important to understand. There are many such cases over there, but this principle, please remember, is only applicable to the civil side and not to the criminal side. Criminal side is to be faced individually. Even the houseman has to face in a teaching institute. So there are many such cases. Communication skills, 67% of the cases can be avoided. I'm again pointing out 67% of the cases can be avoided by proper communication skills, but that is a separate 1-hour talk by itself. And coming to last 3 slides from my side, medical negligence is the COVID-19 era, that COVID-19 necessitated the authorization to telemedicine. This is now given the legal permission after the notification by then MCI on 20th of March 2020, and here it mentions, and it has gone overboard in my opinion, that so far we were saying that telemedicine should be allowed at least for follow-up consultation. They have gone overboard and said that even for the first consultation it is allowed. So even without examining the patient, touching the patient anytime in your life, and without getting full, detailed history of course is possible, but without touching the patient, without interviewing the patient, you can give the first consultation also on telemedicine. So that's one different thing. So this rule mentions that audio consultation, video consultation, or a joint video audio consultation, text communication, text messages, WhatsApp messages, dialogues are allowed, but barring aside the physical examination. This is very important. Barring aside the physical examination, everything else, that means patient identification, informed consent, written consent to treatment part, and whatever advice you are giving are fully the responsibility of the doctor. So if something goes wrong because of your treatment, the liability is on the doctor. So be very careful. In short, what I'm saying is be very careful. And why? Because then therefore, how we can escape? What is the care for that? There must be a disclaimer clause, including the explanation about the limitations in that teleconsultation is a must. So whatever platform you are using, there has to be a disclaimer that these are the limitations of teleconsultation, and it is only on your request that we are giving this advice, and seek the advice of your doctor in person with the nearest doctor as early as possible, because there are obvious limitations. So this is my suggestion, that disclaimer clause should, we already formulated that, and now as per the new Consumer Act, so this is one more I added today morning, that e-commerce comes under it. So even by teleconsultation, all these cases come under Consumer Act, and nextly that you have to preserve the e-records forever. Forever means 3 years, 5 years, whatever. And next point is that these, you have to maintain the confidentiality, which is rather difficult but then their platforms are there. So Dr. Walke is very well aware of this. We follow the same principles in whatever tele platforms he has also developed. So check the confidentiality, what care they are taking. It cannot be assured 100%, but then whether that particular platform has taken care about it, and preservation of e-records forever. These are the things for COVID-19 era. In many countries, this is another point. In many countries, including UK, European Union, and USA, legal immunity is granted while treating the COVID-19 patients as the disease being new. It is yet to be understood completely. Treatment protocols are getting evolved. So what is to follow? So we have demanded in Bombay High Court that immunity on the similar lines should be given. At least there should be an expert committee even for civil cases. They're already there for criminal cases, and every case need not. I mean, there should be as much prevention of possible, legally possible, to go into the courts and putting litigations against treatment while in the pandemic era, because all doctors are overworked and their precious time should not go wasted in fighting only answering the legal notices. Secondly, we also pointed out that extreme shortages of drugs like remdesivir, ambulance services, oxygen, bed availability, lack of infrastructural support causes likely adverse outcome without the fault of the doctor in the hospital. And then whose responsibility? Our courts have already given a directive on this, that doctors and hospitals cannot be held liable legally in this situation. So, but you have to, we have to document that shortage and document the efforts you have done to procure that medicine. So these are the things which have come out of era, COVID era. We I mentioned that we are joined as an intervener in this. So what we have pointed out, that like criminal cases, there should be an expert committee before filing even the consumer cases, or even to serve notices, to save the loss of time, efforts, and harassment and finances of the doctor in this COVID era, when time and availability of doctors is so very importantly precious. So medical negligence one more thing is Epidemic Act of 1897 is amended in 2020, and which says that please note that there are few cases against the doctors and hospitals now under this Epidemic Act. So instead of getting applied to the patients, they are applied to in some patients who have created violence. They have already applied to the doctors. So first cases occurred in Pune, and these are the cases because some contractual doctors in a major hospital in Pune, they took another job in Pandharpur. So actually they were to follow the same duty in ICU there, and the contract period was getting over. They had given 1 month's prior notice, but then the hospital took the plea that our services are getting hampered under this Epidemic Act, and therefore necessary police action should be taken against these consultants. So this is how it is getting applied to the doctors. We cannot, number two, you cannot close the hospital. Even if you don't earn anything, you cannot close the hospital services. You cannot close your dispensaries. Doctors denying practice have been issued criminal action notices. And if you give similar, so in those particular 3 cases, I have given the opinion that because the similar services they are giving at another place in the COVID era, wards only, in ICUs only, and job description is same, though the destination is different, with prior adequate notice, probably they may escape, but the case is going on. So this is what I would say, that important aspects of medical negligence, and some changes as far as medical negligence concept is concerned. So many topics are there, cannot be covered in a period of just 45 hours or 35 minutes. And this is the final slide, and this is to understand the interaction in medical negligence, is that there is a vicarious liability, which I already mentioned. Hospitals are always liable. There is a direct liability. Deficiency in services is wider than medical negligence. Patients put a case against us. There has to be a nexus between the act alleged and the damage claim. Then duty of care is there, whether there was a duty of care by way of established doctor-patient relationship and by way of your contractual obligations, and then comes the doctor. So ultimately, we should not suffer for the want of knowledge of the concept of medical negligence, and hence we take this particular topic always as an opening batsman. Thank you very much, and thank you very much to IMA for giving me this opportunity to explain certain aspects of medical negligence as related to COVID era. Thank you.
You want to say? Thank you, Dr. Naurangi sir, for elaborating such a vast topic in 30-35 minutes. Actually, it is injustice on Dr. Namurangi sir, who can speak for the whole day on this topic. We have just given him 35 minutes.
It's okay, sir. This will arouse
yes.
interest in the public,
Yes.
our attendance, so that they can think of joining the course when we take elaborate courses.
Yes, sir. Yes, sir. We will definitely try to take elaborate courses on this, and we will inform you. Now, I request our President, Dr. B.L. Deshmukh sir, to felicitate Namurangi sir. Thank you, sir. Okay, now we will move ahead to the next topic. That is how to prevent and tackle attacks on doctors. To speak on this topic, we have eminent gynecologist Dr. Dilip Walke sir. Dilip Walke sir is a consultant at Medipoint Hospital and Jupiter Hospital, Pune. He was president POGS, that is Pune Obstetric and Gynec Society, in 2019, 2020. He was chairman of Ethics and Medical Legal Committee, FOXY, 2007 to 2010. He is founder director of Dr. Plaque's telecommunication system. I welcome you, Walke sir. Over to you.
Thank you very much. And the usual two questions, am I audible?
Yes, sir. Yes, yes sir.
And the second thing, I'll share my screen. And the second question is are my slides seen?
Yes, sir.
Okay. I'll just put it in the slideshow. Can you see that now?
Yes, yes. Yes, sir. Yes, you can see it.
Okay. So thank you very much. Thanks to Pune IMA and Meenakshi and Namurangi sir in particular for inviting me here to share my thoughts. This topic, ladies and gentlemen, I am speaking for the third time for IMA Pune. So I thought there are two possibilities. Either Pune IMA committee has liked my talk on the subject a lot, or Pune IMA Medical Legal Committee has totally disliked my talk on the subject and they want to give me another chance to improve now. So at the end of my talk, please tell me whether I was poor, fair, good or great, because I'm trying to improve on this topic for the benefit of all the viewers here. And I know that I qualify for this talk because Namurangi sir knows about my personal experience in 1998 when a mob of 100 held me hostage in my small Walke hospital following death of a non-descent vaginal hysterectomy patient which I had done on the third post-op day, where she died because of myocardial infarction. And in 2008, you all know that there was a mob of 200 which ransacked Medipoint Hospital following a broad daylight case. So probably Dr. Namurangi sir knows that I am experienced with this particular topic, and that's why it has been given to me. The agenda for my talk of maybe 20-25 minutes, or I may cross 30, is that is it only an Indian phenomenon? First, we'll try to see that. Then let's have a look at why Indian clients become so aggressive. Then we'll go for the tricks and tricks to handle a mob violence, and we'll have a look at the statutory laws that are there presently in Maharashtra, the Central Act in case of pandemic, the PIL that Dr. Rajiv Joshi has put in the High Court, and IMA Pune has intervened, as Dr. Namurangi told us. And is there a need for activism by IMA on this particular aspect? That's what we will try to see today. So is it a typically Indian phenomenon? Now, if we were to consider that it is not just about physical mishandling, but if we were to consider that it also includes threats or intimidation or oral abuse, then you will realize that reports from UK, USA, China, Kuwait, Israel, Europe, Australia says that 50% of healthcare workers have undergone healthcare workplace abuses in their lifetime. If we consider not only the physical abuse, but the other abuses also. And physical violence, like in India, is also common in China, Pakistan, Kuwait, etc. And then when you think about why such a global phenomena, the basic reason I think is, in the good old days, religion was stronger than science. And that's why godly magic was used as medicine. And if it failed, the blame was on self. But in present day, science has become stronger than religion, And that's why medicine is expected to act like magic. And if it fails, the blame is on the practitioner. And in India, apart from this, there are some additional factors also. First thing is there is low healthcare literacy in our country. Doctors will talk only about successes. I mean, there are many to talk about the big occurrences that they removed, but no gynecologist will ever talk about the mortality he had in his practice when a case of PPH came, or an amniotic fluid embolism came, or a shoulder dystocia came. No one will talk about that in the media. Media will talk only about failures, because a dog bites a man is not a news, but when a man bites a dog, it becomes a news, and that's the reason why media will talk only about the failures of the doctors and not about successes. Clients will talk bullshit on social media. डॉक्टर लोक कटवर बंगले बांधतात, फॉर्माच्या पैशावरती ऐश करतात, बापाकडे खूप माल होता म्हणून मेडिकल कॉलेजमध्ये ऍडमिशन मिळाली, किंवा कोटा ऍडमिशन वाला डॉक्टर आहे. These are some of the bullshit remarks that we hear by our clients on social media. Politicians treat us like soft targets. I mean, we got fooled with the thali and the fulo ki bauchar that was done in this COVID era. We got just carried away. But they continue to instigate violence. I mean, whether it is whichever the party, you can find out on the social media, you can find out that different party MLAs and MPs have instigated violence against the doctor. The poor patients are frustrated because there is a pathetic condition in government hospital, so they don't want to go to that government hospital. They would want to come to a mid-size or a small nursing home, but there also the cost of treatment is increasing. Even in COVID times, even we as doctors were frustrated to get oxygen bed for our relatives. Even we raised doubt about the treatment protocols when our relatives or friends faced mishap. So spare a thought for a poor person who felt the same but had no money or contacts to get beds or buy the costly beds and drugs. Could violence be an outburst of such a frustration is what we have to do a little bit of introspection about. Now, media instigates us to become intolerant in general. I mean, in the pandemic, that was the time for us to be together. But this media made us believe that my religion is in danger, XYZ religion is trying to convert us, they are terrorists, they are culprits for the spread of the COVID virus, my caste is in danger, my state is in danger, my country is under attack by the enemy, my cow, my temple, my mosque, etc., etc., etc. This is what is happening. Alcoholism and drug addiction is on the rise. We remain vulnerable in our small nursing home because of inadequate security, no insurance, we are poorly staffed, our financial management is poor, we are a single doctor running that place where there is a single entry and no exit. I mean, this is very important for a mob. There has to be some place, because my small nursing home was also such that there was a single exit entry, but no way to run away from that hospital. To top it all, our communication skills are lacking. I mean, these are the usual complaints that are there, which ultimately results in a mob violence. Senior doctor had no time to speak. Junior doctor could not explain us anything. We were made to wait for a long time to meet the doctor. There no empathy was shown while declaring the death, or no attempt was made to resuscitate the patient. So this is where we also lack in our communication skills, and the result is there is violence against the doctor. So let's try to find out how do we tackle this situation when it arises in our hospital. Number one, call the police is the first thing that you have to do. And I always say, when we call the police, call 100, because that is recorded, and we will have complete documentation that you indeed had given a call. And the second advice that I give is, it is better that some female from your hospital calls, because it is a human tendency that whenever there is a damsel in distress, the police officer will immediately raise and immediately come to help you. Second is CCTV cameras all around, and I think now even our corporation insists on it, and we should have CCTV cameras all around in our hospitals. It will help in capturing the evidence of violence, number one. And the second thing that I have realized in my hospital is this: the moment we put the CCTV camera, the politicians who otherwise would come and say, "Bill kami kara, hey kara, te kara," now they have mellowed down when they talk to us in Medicolegal hospital. So this was the other advantage of having a CCTV camera. Make provisions for saving yourself. And I feel that security guards are very inadequate. I mean, most of the small nursing homes and hospitals have security guard. Bouncers provide better shield around us whenever there is a situation in which your life is in danger. But for an individual nursing home, this is a costly affair, having a bouncer. So can we be innovative in Pune and collectively share single bouncer service among group of small nursing homes in the local area? This is what we need to think as a strategy, and that can be a Pune model which can be followed by everywhere, by everyone in the country. Even rogue nations have deterrents. I mean, there is a neighboring nation that we have who will always talk about, we've got nukes, we've got nukes, we've got nukes. Now, similarly, can we have such deterrents in our OPD? Now, no sooner than I show this slide ever in any conference, I am totally ridiculed by many of the faculty members and many of the delegates, because I can understand. I mean, generally we doctors are very minnows and we are stereotyped to be soft and gentle. I mean, this has been put in our head that as a doctor you have to be very soft, you have to be very gentle, and that's the reason why we consider it as our moral duty to suffer, to refrain from asking questions, to at the most arrange some rallies, to put in writ, and PILs are left to only the daring activists amongst us like Dr. Rajiv Joshi and Dr. Naurange. But the rest of the things, the rest of us are ready to suffer, and that's the reason why we don't even want to talk about having a pistol license or having some deterrence in our hospital. But I'll leave it at that. I don't want to discuss it any further, because then the whole discussion goes in some different direction. Tip number 4, insurance. Insurance for damage to furniture, riot, fire, calamities, etc. The premium is very meager for Medipoint Hospital, which is a big, about 80 bedded hospital. The premium for this is only 3,500 rupees. So you should all have an insurance for this purpose also. Tip number 5, rush team. Now, I always say, and this has been discussed many a times in our IMA forum, that we need to have a local rush team while declaring a death, and that the death has to be declared in presence of this rush team. But what is not discussed is the members of the rush team, please do not instigate. Do not occupy the chair of the owner. You don't do the talking. Let the owner do the talking. Let him do the communication. And only if the communication is taking a bad turn, that is the time you need to interfere and talk. I mean, that is not a place where you take an opportunity to settle your professional score, because you being the senior member of the rush team, it is bound to be a fact that because of this new person coming in your local area, your practice may have come down. But don't take this as an opportunity to settle your professional course and give in and remark in front of the relatives, which might instigate more litigation than try to solve it. Many times people ask me, what if there is a life danger to my life, and what if I run away? There is no harm. Even the courts are not going to take any bad view about this. If you say that I ran away because my life was in danger, this is not an act of cowardice, because your life is as important to you and it is important to the courts also. So that's the reason why if you feel that your life is in danger, you can run away. Take photographs. Now take photograph of the damage done to the property as an evidence that is required by the insurance company and by the court also, and do this before the politicians arrive, because there is a possibility that the group of people who have done the violence are the vote bank of the politician, and he may want to erase all the evidence, and he might just come and say, चला आपण हे सगळं स्वच्छता करून टाकू, म्हणजे उद्या सगळं आपण चकाचक आपलं हॉस्पिटल करू. What he's trying to do is erasing the evidence of the damage done. So you take the photograph before he comes and does any cleaning work in your hospital. Medical checkup, of course, is very important, preferably to a nearby government hospital. And if the government hospital is not there, it's an emergency, you can do it in a private hospital also, but preserve all the papers as the MLC report. Involving politicians. Now, if a medical legal expert tells you that calling a known politician is a double-edged sword, and that they will take advantage from you in the future for having helped you, so please keep them away. If any medical legal expert is telling you that, do not be fooled. Because my take on politicians is, in this situation, they will any which ways come. Whether you call them or you don't call them, the moment there is mob violence in your hospital, they are bound to come there. And second point is, even if you ever needed them in your lifetime, then it is on this day when your life is in danger, your life of your staff is in danger, and the life of your family is in danger, because many a times our nursing homes are near our residence also. So that is the reason why I feel you don't involve politicians in every small medico legal case, but whenever there is a case of mob violence, that is the time these politicians, from whatever varganis that we have given for the Ganpati or whatever party funds that we may have given, make use of the politicians today, and not for any other medico legal case. And I've seen many a medico legal experts using their political connection when personally they are facing such a situation. They may come on the dais and say don't involve politicians, but whenever there is a problem occurring in their own hospitals, they have involved politicians. So don't be fooled by them also. Now coming back to the police, when the police comes, they have got two things to do. One is an inquiry for medical negligence and an inquiry for mob violence. For medical negligence, they'll come and they'll take statements and they'll take copy of the papers. So while you're giving the papers, number each paper, take signature on each paper, and you can give the copy, or sometimes they may even ask you for the original. For inquiry of the mob violence, please mention the names of the miscreants if you know them. Hand over the CCTV footage to them. Insist on an FIR. Now, under the prevailing act, you can insist on an FIR. If the miscreants are known, then you tell them to make an FIR against the miscreant. If the miscreants are not known, still you can make an FIR on the unknown. It is up to the police to find out who actually did the mob violence. Now, delay of arrest. Delay of arrest is logical in view of the possibility of a law and order issue which may arise after, because these people who are miscreants have lost their relative, their near and dear one. If they have lost their near and dear one, and if they are arrested, there can be a law and order problem in that local area, accepted. But if it is getting delayed even beyond a month, 13 झालं, महिना झाला, 10 झालं, त्याच्यानंतरही they are not arresting, then the options are: one, you try to find out some senior police officer which the IMA Pune will have contacts with, and try to see that the arrests are done, or you can have an ITR, or you can take help of the media, and the last resort is writ petition. But in MediPoint, thanks to the help that was given by Dr. Naurange sir, we contacted the senior police officers, we made an RTI, media gave us a good support, and then the miscreants were arrested. 10th point, insurance. Inform the insurance company for damage with the help of the photographs that you have taken, the FIR and the medical certificates. Keep a copy of the prevalent acts with you. Prevalent acts are two at this moment of time. The prevalent act which is there in Maharashtra, and the central act which is prevalent only during COVID time. Now the act in Maharashtra, like in Karnataka or AP or Andhra Pradesh or Orissa or Chhattisgarh, this is what is called as the act that has come in 2009. Now this is prevalent when it is a non-pandemic time. So it is going to be prevalent when the pandemic gets over. And it talks about commitment, abetment to commit, and attempt to commit, and of all kinds of vandalism against the doctor and the institution. There is an imprisonment of 3 years and a fine which can extend to 50,000 rupees, and a compensation double the amount of loss to or damage to the property as judged by the court. It is cognizable, non-bailable, triable by the court of the judicial magistrate first class. Even if you don't understand this, this is okay. But what you need to understand is that it is non-compoundable. It is a crime against the state. So somebody is coming to you and telling you, ती केस परत घेऊन टाका ना, त्या मुलाला बिचाराला त्रास होतो या मुलांनी जे व्हायलन्स केलंय, तुम्ही ती केस परत मागे घ्या. First the politician will come, then the local gunda will come and try to instigate you. Tell them that private parties do not have any right to settle the dispute. It needs a writ in the High Court. So I am not going to be pressurized by you to take the case back, and do not succumb to this pressure that can come from politicians and underworld. And during the pendency of the case, which is going to go on for years together. In my case of 2008 Medipoint hospital violence is still going on. Do not lose interest as it goes on for years. Attend the court on the given date. Help the public prosecutor with all the evidences that you have. Because I feel that only one conviction and there will be a difference in our Pune city. So I'm trying to do all that I can to see that those three or four people who did the violence in Medipoint hospital, they are convicted. If there is even one conviction that comes out in the paper, the others will learn their lesson. Now, IMA is doing advocacy to have it as a central act. There is an act, this act in Maharashtra cannot be only restricted to Maharashtra. One thing is it has to be a central act, and it has to be an act which is similar to which is now prevalent during the pandemic time, because the pandemic time act has got stronger teeth than the act that is there for Maharashtra. And let's have a look at why it has got a stronger teeth. Number one, it also includes harassment and intimidation. So the whole scenario has increased now that harassment also is going to be punishable. Intimidation will also be is going to be punishable, and it talks about 5 to 7 years of punishment, 50,000 to 5 lakhs of compensation, plus double the amount of damage depending on the severity of the hurt caused. It too is cognizable. It too is non-bailable, triable in the judicial magistrate first class, and that too is non-compoundable. And what is the stronger teeth that has been given to this particular act? This is going to be investigated by an officer who is of inspector or above rank, number one. Number two, he is supposed to finish the investigation within 30 days of the FIR. And number three, the trial is supposed to be completed by the court within 18 months. And another thing is the offender is considered to be guilty till proved not. I mean, usually it is that the offender is considered to be not guilty till he is proved to be guilty. Here, the offender has to prove that he was not guilty in this particular time. Now, even the government of India, supposing passes such an act after the pandemic is over, and similar act, the government of India makes it a central act with similar strong tooth, supposing if it is done, still, are we ensured about a proper implementation? Then we tend to think that despite some strong acts, why is the police or the government not interested in protecting us doctors? And Dr. Raju Joshi is asking similar questions in his PIL. And IMA Pune has intervened for the same reason. But despite whatever act that we are having, it is not being properly implemented. The government of India and the police does not seem to be interested in protecting us doctors. We doctors are basically not their powerful vote bank. This is what we need to understand. We are not their vote banks, and they are not going to take care of us. Because traditionally and globally also, law enforcement, I mean, don't think that it is only something which is there in India. It is there in USA also, traditionally, globally. Law enforcing and law making authorities protect powerful versus powerless, white versus black, men over women, powerful upper class over powerless lower class, powerful upper caste over powerless lower caste, rich and connected over poor and underprivileged. So till such time that we all doctors don't become powerful, our fight against this traditional system will continue. We need to be collectively powerful, and being collectively powerful means that we need more people like Dr. Raju Joshi. We need more activists like Dr. Navrange and all the office bearers of Pune IMA for becoming flag bearers for this power struggle. And only then that the doctor community will be seen as a powerful community which can influence a big vote bank. And I think this particular topic of how doctors as a community, how IMA can become a big vote bank is a topic of discussion for some future conference. But time has come that we need to think about being, being such that our voice will be heard by these politicians and these lawmakers. I thank you very much for patient listening, and I especially thank Dr. Navrange sir and Dr. Joshi for being so proactive in the PIL that he's filed in the High Court. Thank you very much.
Varke sir, we always call you for such an important topic because you always make a new attempt to have newer and newer inputs.
Yeah.
And secondly, of course, you're a very such interesting speaker, giving you not only making it very interesting, but giving us the real points. So every time something new comes up, so maybe next time we'll remember that we'll not give you this topic, but something else. You will entertain us again, same way.
No, sir. I'm all whatever topic you give me, sir, for Pune IMA anytime, any day.
I know. I know. You have talked about MTP. You have talked about ambulance, referral notes. So many things we have been covering. I mean, this is out of joke only. Thank you.
Thank you, Dr. Varke, for your excellent talk and giving so many tips and so many practical approaches how to tackle the attacks by the patients. So now I will request our President, Dr. B.L. Deshmukh, to felicitate you.
Sir, this is bouquet for you.
Thank you, sir. Thank you very much.
Virtual.
We are so especially grateful because you have another conference going on simultaneously.
Yeah. So I'm going to log out from here and go there then.
Yes. Thank
Sir,
you.
I am Uparna for you.
Thank you, sir. Thank you so much.
Okay.
Thank you.
Thank you so much.
Thank you, Dr.
All the points were very nicely put up, Dr. Dilip, especially the Epidemic Act. You have explained very nicely the teeth of the Epidemic Act, which is.
Thank you, Meenakshi.
Yeah.
Welcome, Meenakshi.
Yeah.
The next speaker is Dr. Meenakshi Deshpande, and she will be speaking on latest amendments, one on MTP Act, CPA, and Epidemic Act. I will shortly introduce Dr. Meenakshi Varke.
Hey, Meenakshi Deshpande.
Meenakshi Deshpande. Dr. Meenakshi Deshpande, she is MBBS, MD, obstetric gynec. She's from BJ GMC and Sassoon General Hospital. She's a senior consulting obstetrician and gynecologist, practicing since 28 years as high-risk pregnancy consultant. She's a director of Vatsalya Hospital, Sinhagad Road, consultant Krishna Hospital, Poud Road. At present, she is a president-elect of IMA Pune. She is a chairperson of IMA Pune, Medicolegal and AMS committee. She is IMA National Standing Committee of Initiative for Safe Motherhood member of IMA Delhi headquarters, LTCWC member, recipient of following awards. She's got IMA HQ Dr. Kanak Goyal Award for exemplary work in women's health and family planning. Apulki Award for work in women's social issues for consecutive 2 years, and IMA National and MS President's Appreciation Award for 2 consecutive years. She is a master trainer of Foxy VAW cell, member of Foxy representative, NIMC National Inspection and Monitoring Committee, PCP entity, GOI. Thank you, Meenakshi.
Thank you.
I think I will not come in between you and delegates. So please start.
Yes, thank you, Alka, for a very exhaustive introduction. And am I audible and can you see my slides?
Yes, you can start, Meenakshi.
Okay. You can see my slides now?
Yes.
Okay, thank you. So I would like to thank Naurange sir for giving me this topic because he wanted specifically me to speak on the latest amendments in the CPA 2019, the Epidemic Act and the MTP Act. So I will not be elaborating on the original acts, but I'll be only speaking on the amendments what have come forward in the previous years on these acts. So because everybody of us know that all the acts need to go into amendments as per the current scenarios, current situations, and the current PILs which are faced by the courts and the Supreme Courts, especially the High Courts. And then we can get these amendments which are there for our own benefit. So everybody of us should know this Epidemic Act, CPA Act, and the MTP Act amendments which are the latest in our practice. The Epidemic Diseases Act has already been partially covered by Dr. Dilip Varke, but I will just focus on the few new things. First of all, this amendment or the ordinance, it is called 20. So this has come after the onset of the pandemic. And it amends the Epidemic Diseases Act of 1897, which is for prevention of the spread of dangerous epidemic disease. Now, what are the changes made in the original act is that it includes the protection of a healthcare personnel which are combating the epidemic diseases and expand the powers of the central government to prevent the spread of such diseases. So these 2 new points have been added. Definitions have been added, like an act of violence not only includes the violence act, but now it also includes the harassment, the harm, injury, hurt, or danger to the life to the healthcare personnel, obstruction in duties, discharge of the duties. That is, for example, if a healthcare worker is obstructed on the road for reaching to the hospital for his own duties, even that comes under the act of violence now. Suppose your sister, ayah, staff, or any ward boy is obstructed on the road by that personnel, even that is taken as an act of violence. The fourth point is, of course, the loss and damage to the property or documents. If the documents are stolen, torn, burnt, or destroyed by the personnel, then that is also taken as an act of violence. The B in definition is of property. But the property is redefined to include clinical establishment, quarantine facility, mobile medical unit, and other any property in which a healthcare service personnel has a direct interest in relation to epidemic. It will also include whatever the transport facilities which are there for transporting a patient. That is really include an ambulance. If there is any destruction to the ambulance, car driver or car of the doctor, even that is taken as an injury or harm to the property. Now again, this ordinance also specifies that no person can commit or abet the commission of an act of violence against any healthcare personnel during an epidemic. And if contravention to this provision is punishable with the imprisonment between 3 months and 5 years and a fine between 50,000 and 2 lakh rupees. This offense may be compounded by the victim with the permission of the court. But if an act of violence against an healthcare person causing grievous harm, then these offenses are cognizable, non-bailable, and non-compoundable. The punishment given is also, we just see it has increased. Imprisonment between 6 months and 7 years, and fine between 1 lakh rupees and 5 lakh rupees. So this is the teeth which Dr. YK was focusing on, that this is the teeth which are increased in the time of pandemic. And this is what we are also expecting a central law to say all these things, because we have to regulate the instances of violence, and the instances of violence and assaults on doctors will not stop unless a central law is made in which the violent perpetrators are really punished. Now, this act also specifies that the original act says that the central government should regulate the inspection of any ship or vessel leaving or arriving at any port. Because this act was made in old times, it was made in 18,000. So that time only the way of communication was ship or vessel. But now this ordinance expands the power to regulate the inspection of any bus, trains, goods vehicle, vessels, aircraft, leaving or arriving at any land, port, or aerodrome. So the central government can now regulate the detention of any person intending to travel by all these means. Persons convicted of offences are also liable to pay compensation to the healthcare personnel whom they have hurt. Such compensation will be determined by the court. In case of the damage or loss of property, the compensation payable to the victim will be twice the amount of the fair market value of the damaged or lost property as determined by the court. So the court will determine the approximate costing of the property, and twice the amount of that value has to be compensated by the persons who have done the violence to the doctors or the hospitals. If the convicted person fails to pay this compensation, the amount will be recovered as an arrear of the land revenue under the Revenue Recovery Act of 1890. So this is a new addition to the current pandemic law. Cases registered under the ordinance will now be investigated by a police officer not below the rank of an inspector. Investigation is to be completed within 30 days of the first registration of the FIR, and the inquiry or trial should be concluded within 1 year. So if it is not so, this current Epidemic Act changes or amendments also brings upon some time-bound compulsion on the judiciary. Because if it is not concluded within this time period, the judge is expected to record the reasons for the delay and extend the time period. However much the time period he can extend, it cannot be extended for more than 6 months at a time. So when prosecuting a person for causing grievous harm to the healthcare service personnel, the court will presume that the person is guilty of offense unless the contrary is proved. So these were all the amendments in the new Epidemic Act, and also the similar which we are asking for a central law, because all these are the state laws. So all the violence and the assaults on doctors are now, Epidemic Act is under the state, which we are from IMA Pune, and not only from IMA Pune, we are also asking from a IMA, central IMA, to make it into a central act. The second is the Consumer Protection Act 2019. Consumer Protection Act, everybody knows how the medical service personnel and the healthcare workers and the doctors were there in the original act. But suddenly when these amendments came, everybody thought that because this is excluding the healthcare system, everybody was very happy for a few days that yes, we are not under the ambit of Consumer Protection Act now. But remember that as we are service providers, we are still under this Act of Consumer Protection Act 2019. What is changed in this? The changes are come because of the digital era of commerce and digital branding, and these provide easy access, a large variety of choices, and this has brought more challenges related to consumer protection. So keeping this in mind, a landmark judgment, Consumer Protection Act 2019 aims to provide a timely and effective administration and settlement of consumer disputes. So this replaces the age-old Act of 1986. Remember that this act replaces the original act. So what are the key highlights? Is it has widened the definition of consumer. Now it includes any person who buys any goods, whether through offline or online transaction, electronic means, tele-shopping, direct selling, or multi-level marketing. So all these types of marketings have been included in the definition of the consumer. Second change is the enhancement of the territorial jurisdiction. In 2019 Act, an additional advantage is made to the consumer by providing that the filing of complaints where the complainant resides or personally works for gain can be done. And what the Act says is that this would help in removing the difficulties faced by the consumers in seeking redressal of their grievances against the businesses who may not have an office or branch in their area. So even if you are not having your clinic in that area or your area of practice is not there, if the patient is from Assam, if the patient is from Delhi, patient can file a consumer complaint from there, even after patient has shifted his residence or the workplace. Now, how does this affect our doctors? Is that the district forum is that, yes, I'll talk about this later on in my next slide, it is coming. But this will also help us that we can have an online consultation. The electronic media is used to file the complaint. So I will tell you about this a little later. We go to the third change, the district forum. There's enhancement of pecuniary jurisdiction. The district forum can now entertain consumer forum complaints where the value of goods does not exceed 1 crore. The state commission entertains disputes where the value exceeds 1 crore, but it is below 10 crores. And the national commission can exercise jurisdiction where the value of complaint exceeds 10 crores. So now we have to have a speedy resolution of the disputes for the referring the disputes to the mediation. So consumer forum should refer the matter to mediation on written consent of both the parties. So establishment of a consumer mediation cell by the respective state governments as well as state commission, national commission is now allowed. Now this was the point which I told you I would come to is the e-filing of the complaints. So even if your complainant is say out of your remote area, the complaint can be electronically filed in accordance to the rules which are prescribed by the government and for hearing. And the examining parties and the court can do all this hearing through video conferencing. So this is the flexibility which we can have, that we are as doctors, we may not be able to attend the court, but we have to attend the video conference. That is, we see meetings which take place, and when we are summoned to the court, we see while giving our evidence. The new act also provides flexibility to the complainant saying that the jurisdiction consumer forum located at the pace of work is for the procedural ease. So maybe it is a procedural difficulty for our own as a doctor, but maybe if we do it as a video conferencing, it will be an ease for us, which reduces the inconvenience and harassment, not only for the consumer, but also for us, because we need not go to that area. We can join by video. Also, a few more features which are there is a corporate bodies can also be sued under this Consumer Protection Act. Medical services are there, absolutely there, which are to be rendered in accordance to the law, and they are under the purview of this act. And this is also applies for the educational institutions, wherein extra fees, if they have charged, have to be refunded if the consumer feels so. A few example court cases I will now like to highlight. First will be of Dr. Arvind Shahan versus Kamlaben Kushawa. See now how this case has gone. This case has risen because of the death of the complainant of Kamlaben Kushawa's 20-year-old son, which she says is due to the medical negligence by the petitioner doctor. The mother alleged that medicine prescribed had no relation to the ailment, malaria, whereas the actual cause of death was said to be pulmonary edema. The doctor alleged that he did not diagnose the deceased for malaria because pathological tests are necessary to establish that conclusively, and no such report was made available to him. That means the doctor has not inquired for the past history of malaria in which he was suffering. And when the patient came to the doctor, he has diagnosed something different, and he has given treatment with different view, and the patient has died because of pulmonary edema. So the state commission found the doctor guilty of medical negligence and awarded a compensation of 5 lakh rupees with the interest of 9%. But this case was appealed by the doctor in the National Commission. So now just see what the court has taken a stand. The court has taken the stand of Supreme National Commission that even when the doctor is treating a patient, even outpatients, the doctor is under a responsibility to record basic health parameters like blood pressure, temperature, pulse rate. Of course, this has been told by MCI as well. A doctor cannot rely on what the patient says orally, but doctor should make his own notes of the summary of the symptoms. The past illnesses should be covered, and it's a primary duty of the disclosure owed by the physician to the patient. And thus, if a proper prescription is not given because of failure to record the patient condition as per the reports, then it is a guilty. The doctor is said to be guilty. The notes also deny the denial of the doctor having written the prescription served as evidence in the first place, but later on accepts that treating the patient is important. But the conduct in the language of the commission does not reflect professional conduct worthy of the medical practitioner. So the National Commission of the Courts expect the doctor to take out the past history, do proper notes, write all the clinical notes of the patient on the valid prescription, and then give the prescription to the patient, because that is a form of a record. So the commission noted that while the doctor is indisputably held guilty of the medical negligence by not issuing a proper prescription, there was no material available to conclusively establish the negligence of the doctor with the cause of the death. So the National Commission just decreased the amount of damages to 2.5 lakhs. So the doctor has held a doctor guilty, the court has held a doctor guilty, but because of the improper documentation by the patient also has not given a proper history. So the claim was divided into half, and the compensation was given only half. So one more case which I can just highlight over here is of a 20-year engineering student who was admitted to a Nizam Institute of Medical Sciences after he complained of chest pain. Several tests and x-rays were done which revealed a tumor. However, it could not be ascertained whether the tumor was malignant or not. Therefore, the patient was advised to undergo surgical removal of the same. After surgery, the patient developed acute paraplegia with complete loss of control over lower limbs and other related complications that led to urinary tract infections, bed sores, etc. The family of the patient held NIMS vicariously liable and the state of Andhra Pradesh statutory liable, being the government hospital, for the negligence of the doctor concerned. So allegations were primarily leveled against a doctor, that is P.V. Satyanarayana, for negligence before, during and after the operation. So total compensation awarded by the Supreme Court was 76 lakhs. Now just see this case in government hospital. Father had pleaded with the doctor. What were the points which went against the doctors? The points were that the father had pleaded with the doctor saying that allow him to finish his education before undergoing this surgery because there was no emergency or immediate danger to life. But still the operation was conducted because of the doctor's insistence. Second thing, there were no preoperative tests conducted. Third thing, operating on a tumor which had neurological implications, neurosurgeon was not consulted or called or even taken an opinion of. The fourth point which went against the doctor was consent was taken only for tumor excision, but doctors removed not only the tumor but also the surrounding ribs, the tumor mass, the destroyed blood vessels. That led to the condition of paraplegia for the patient. So what the Supreme Court expects from the doctor is implied consent to operate is assumed. You cannot have an implied consent that a patient has given a consent to remove the lump. So that does not imply that the patient has given consent to remove all the tissues around the lump also. So implied consent is assumed over here. That is what the Supreme Court said. Doctor has not followed a practice acceptable to the medical profession. Supreme Court said that whatever a normal thinking doctor, a normal medical care should be given is not accepted, not followed in this case. Compensation awarded was so huge because it is a balance between many parties and interests, because the father had to look after the son. The son was 20-year-old, his education, his whatever he was learning, he might have looked after the parents, and all these things was taken into consideration before awarding the compensation of 76 lakhs. So you have to remember that all these things come under the Consumer Protection Act now, and this was the latest judgment. So the new act also has a broad definition of unfair trade practices, in which sharing of personal information given by the consumer is in confidence, and you are not supposed to share this confidential information to anybody except under the provisions made by any other law. In this concept of the second Consumer Protection Act, this will be my last slide because this applies to us also, that the new act fixes liability on the endorsers, where influence of celebrities acting as brand ambassadors, and it becomes important for the endorser to take the onus and exercise due diligence to verify the veracity of the claims made in the advertisement. So if in your advertisement you claim certain 20 things, that we will be doing this, we'll be doing that, we'll be available 24/7, you have to be endorsing that and following that, because if that is not there, then there can be a penalty for misleading advertisement by any doctor, hospital, any healthcare establishment. This can be a penalty of up to 1 million rupees on a manufacturer or a misleading advertisement, and also to imprisonment of 2 years for the same. Subsequent offense, the period of prohibition may extend to 3 years, because this can be prohibited for 1 year, and on subsequent offense, the prohibition period can be extended to 3 years. Now, as compared to the 1986 Act, the present Consumer Protection Act shows that it provides for the greater protection of the consumer interest, taking into account the current age of digitalization and also the technological advancement in the industries, which provides for easier filing of complaints and imposes strict liability on the businesses, including the endorsers. So we should remember all these points for the new Consumer Protection Act, which has totally changed. Now we come to the last part of my talk, is the MTP amendments, the medical termination of pregnancy. Everybody knows what is the basic law. Now this amendment has come in 2020 because on January 19, 2020, the Union Cabinet has approved the MTP Act, and the medical termination of this recognizes the safe, affordable, accessible abortion facilities and the need to terminate the pregnancies for specific and special circumstances which were not tackled, which were not handled in the previous act. So the first and the most important, yes, it was introduced in the Lok Sabha on March 2, 2020, passed in March 17. It has got the approval of the President India, and now it will be coming shortly in the Gazette. Now, we have increased the level of termination from 20 weeks to 24 weeks. This is certainly applicable for categories like differently abled, mentally retarded, for pregnancies due to rape, and especially for the survivors of the rape, incest, and any other abnormal sexual act. Plus, in case of substantial fetal abnormalities, there is no upper limit. Only thing is that a medical board should certify, and all this grounds has been created because of the innumerable PILs which has been put in by the companies, by the patients, by our doctor community to the Supreme Court. And this is the result of these amendments, are the result of all these fights which have been given for the past 5 years. Several cases have been filed before Supreme Court and various high courts seeking permission for aborting pregnancies at stages beyond 20 weeks. And because of the advancement of medical technology, there is a scope to increase the upper limit of terminating pregnancies, especially for vulnerable women and severe fetal abnormality. So this amendment has come into place. So what are the changes? Is the MTP Act 1971 and the MTP Bill 2020. Up to 12 weeks, it was advice of one doctor. Up to 12 weeks, yes, the same condition applies. But from 12 to 20 weeks, we required advice of 2 doctors according to the old Act, 2 RMPs, whereas here advice of only 1 RMP will be okay from this when this law starts coming into action. 20 to 24 weeks MTP was absolutely not allowed, but here in this amended bill, for 20 to 24 weeks, we can have 2 gynecologists or 2 RMPs signing the papers, and for special categories of pregnant women, they are allowed. And for more than 24 weeks, we have to have a medical board to certify a substantial fetal anomaly or any other problem. If medical board certifies, we can do an official MTP after 24 weeks also. Now, what are the medical boards and how are they constituted? All state and union territory governments will constitute a medical board, and this board will decide if the pregnancy can be terminated after 24 weeks. Now, this board will have to have a gynecologist, a pediatrician, and a radiologist or a sonologist, and other members notified by the state. Dr. Sunil, can I have 2 minutes or shall I end?
You can continue for 2 more minutes, madam. No problem.
Because only few slides are remaining.
No problem.
Yeah. So termination due to failure of contraceptive device was there. But remember, this indication was to be applied only by married women as per the old act. But now this bill allows unmarried women also to terminate this any pregnancy for this reason. So you can now tick on the married woman failure of contraceptive, which was, failure of contraceptive, this can be applied for unmarried women also with a partner. The privacy of the patient and the woman has to be utmostly taken care of, because violation is punishable with imprisonment up to a year, a fine, or a both. So this is a new addition to this law. And thank you for patient listening and for wishing you all a litigation-free practice with a full knowledge of the newest amendments and the newest law, whatever we are come under now. We are time bound to learn these laws now. So thank you, IMA Pune. Thank you, Dr. Naurange sir, and thank you, Dr. B.L. Deshmukh sir.
Thank you.
Thank you, Meenakshi madam. Thank you very much for explaining the delegates about the new amendments that have come in CPA, Epidemic Act and MTP Act. Thank you very much. I request B.L. Deshmukh sir to felicitate Meenakshi Deshpande madam.
Thank you, thank you.
Madam,
Thank you.
Thank you.
become bouquet for you.
Thank you.
Thank you.
IMA Upparna.
Deshmukh sir, I will take a real bouquet from you.
Okay, okay.
Yes, sir. Thank you. Thank you.
Okay.
Real opener also.
Yes, sir.
Okay, we will move on to the. Yes, yes. We will move on to the next lecture. The next speaker is Dr. Aniket Joshi, who will be speaking on
Tackling emergencies.
tackling emergencies during COVID. Dr. Aniket Joshi is MBBS, FCPS medicine, and moreover, he has done certification in health informatics from Australia. He is a consultant physician, intensivist, and is associated with many hospitals like Pune Hospital, Sahyadri Group of Hospitals, Tarachand Hospitals, and I don't think I can mention such a big list because he is attached to almost all the ICUs in Pune. He has done extensive work during COVID pandemic in ICUs, wards, OPDs, and telemedicine. He is at present working as a physician intensivist since 2000 at various hospitals in Pune. He is ICU in charge of ICU number 3 in KEM hospital since 2015. He has extensive experience in IT projects of various organizations since 2000. I welcome Dr. Aniket Joshi sir for his talk. Over to you, sir.
Thank you, Dr. Ingle. Am I audible?
Yes, loud and clear.
And thank you for this kind and elaborate introduction. I am, along with this, very happy and proud to say that I am active member of IMA, and IMA has helped us tremendously during this COVID era. And I really thank from my bottom of my heart to all members of IMA who have been very, very active and vocal in media as well as on social media, in front of authorities and in front of politicians, also to help COVID warriors do their duty. Now, I really sincerely thank all of the IMA members for being so cooperative. So, shall I start my talk?
Yes, sir. Yes, sir.
I thank IMA again to give me this opportunity to talk about tackling emergencies during COVID-19 era. There were a lot of challenges. I mean, these emergencies can be also called as challenges. So, while we got exposed to COVID-19 in early 2020, it was a total chaotic situation, and every case we did not know, as we were trained in our postgraduate curriculum and in our life to be compassionate and to be able to handle the patient effectively within as early as possible and give the best possible treatment to the patient. There were a lot of challenges right since the beginning of this COVID-19 pandemic. So first, there were many types of emergencies which we had to face, and because of which tackling COVID-19 patients was a very big challenge in front of the people who were actually doing the frontline work. First and foremost, I would like to highlight these emergencies. I in fact thought about it, and I classified them into various subheadings. First and foremost was medical emergencies. Then there were administrative emergencies. Then there were infrastructure related emergencies. There were political emergencies. There were legal emergencies, social, financial, and others. Next slide, please. We all know what medical emergencies were there in the COVID-19 patients. And COVID-19 patients used to present to our different situations. In first and foremost was hypoxia. That is a reduction in the oxygen level. Everybody knows about hypoxia. So these patients used to present with hypoxia to the clinic also. And from there, and when we used to ask them, are you having any symptoms? Majority of them did not know unless they got to their pulse oximeter check, oxygen level checked on pulse oximeter. And from there, we used to diagnose that this patient has hypoxia and used to take for chest X-ray or CT scan or further investigations and further treatment. So hypoxia was a major emergency in which patient did not feel any major symptoms. They used to say, I'm feeling extreme weakness. Any small activity I'm trying to do, I'm feeling extremely weak. And they used to be flushed. The face used to be flushed, and there used to be associated tachycardia. So such patients usually presented to the clinic first, and either the clinic or the emergency situation or the casualty of various hospitals, they used to start getting these patients of they started getting these patients of hypoxia in large amounts, and from there onwards the treatment is to start. First challenge was to start oxygen. After starting oxygen also, the hypoxia did not get corrected to that level. From there, we used to start giving further treatment, and we used to take care of the hypoxia and further management. So in that, we used to use immediate, we used to use the short-term steroids, nebulization as was indicated. Then low molecular weight heparin and further treatment was added. And these patients were shifted to isolation wards or ICU as per their oxygen level. They were also started with non-invasive ventilation, and sometimes we required elective intubation at the beginning of the treatment itself. Most of these patients used to uh, very rarely, most of these patients used to respond to these various treatment parameters. Very rarely we found that these patients did not respond and succumbed at the beginning of the treatment itself. But the patients who presented late and had very severe hypoxia, their prognosis in the long run was not that good. So patients who presented with respiratory rates of more than 40, 45 and with the oxygen level of less than 80, they had a bad prognosis despite giving all sorts of treatments. They were actually late presenters. They were having the disease. They took treatment on OPD basis. Some non-specific treatment was allocated to them. They did not get any particular proper channel. The investigations were also dilly-dallying, and it was not related to actually education level also. In most of the affluent societies also, there was a lot of denial. People used to say with the fear of quarantine or with the fear of very different social stigmas related to COVID or whatever the reason might be, they used to avoid doing RT-PCR. Or sometimes what used to happen is that these patients used to get RT-PCR done. It was reported as negative because it was done before the symptoms appeared or before the viral load was significant. And then after the first RT-PCR, when the patient used to start getting symptoms, then the patient was reluctant to get the second test. So, and after that, the symptoms used to get aggravated, and because of which patient used to land up with hypoxia. So hypoxia was the most hypoxia. So hypoxia was the most important presentation or medical emergency which all of us used to tackle. And it was so common that every person we started getting calls on phone only that the patient, they used to check the oxygen level at home, and they used to call at any time of the day saying that my oxygen level was 60%, 70%, and now what to do. And that time everything was so overburdened that finding the appropriate place in these cases was also a very big challenge. Majority of the times they used to get placed, but in a few conditions where they did not get placed despite trying for hours together, it was a few incidents have occurred in which the patients have succumbed before getting the appropriate medical treatment also. Second important medical emergency which used to see is altered sensorium. Patient used to come with altered sensorium with GCS less than 10 to 12. There used to no preceding event or subtle presentation was also there, where patient used to get sudden unconsciousness or patient used to slowly deteriorate on uh, 3 to 4 days and used to present with altered sensorium. First, there used to be confusion, then there used to be lethargy, and then after that, the patient used to present with unconsciousness. So in that case, we used to take the patient's history, then do the examination and take the appropriate steps like doing a CT scan, first airway breathing circulation, and then further MRI and further treatment. COVID encephalopathy was a very common uh, presentation of medical emergencies. Third was arrhythmias. There a lot of myocarditis was seen, therefore a plethora of arrhythmias. In fact, COVID-19 had actually revised the entire systemic or all emergencies known, unknown in the past curriculum has been presented in this particular scenario. Arrhythmias were very common and all sorts of arrhythmias were seen because of myocarditis in COVID emergency as well as in thrombosis also, because of thrombosis also. So myocarditis as well as thrombosis being the underlying factor. And most of these patients had comorbidities which were aggravated by COVID-19 disease, but few of them did not have any comorbidities, young people, but they used to come with arrhythmia. So commonest was atrial fibrillation, but we have got other arrhythmias also, serious ones also, but atrial fibrillation was very common in this scenario. Then diabetic ketoacidosis. Most of the many patients who did not have hypoxia but were tachypneic, they used to present with diabetic ketoacidosis with who had diabetes or were pre-diabetics in the earlier before COVID-19. They presented as diabetic ketoacidosis. Acute myocardial infarction was a very common scenario, but these people did not have active COVID disease, most of them. They had very mild COVID disease, which probably got masked, or they did not understand that they had got COVID disease, and they directly presented with acute myocardial infarction, ST lesion, MI. And the disease was related to acute thrombus in the coronary circulation. Again, stroke also was the same. They used to present with cortical sinus thrombosis, and they used to present with slides are going to change. So they used to present with cortical sinus thrombosis, and they used to present with acute ischemic stroke also. Fortunately, the hemorrhagic strokes presentation was less than the ischemic stroke. Bowel gangrene was a very common presentation, acute abdominal pain and abdominal distension associated with tachycardia, hypotension. And when on the examination, we used to find distended bowel. And again, it was the underlying pathology was thrombosis. Patients used to present with cytokine storms also in a few of the conditions. They have presented with tachycardia, hypertension, tachypnea. Then they have presented with severe chills and rigors and very high grade fever, 104. And patient used to actually jump, and usually these episodes, they used to last for say few minutes, like 40-45 minutes. They used to be continuously shivering, did not respond to our regular treatment of short steroids. Sometimes we used to give labetalol also for controlling blood pressure. Then gangrene, I'm sorry for the typo. The gangrene was a very common situation where peripheral vascular circulation or peripheral arterial circulation used to get, again, these blocked because of thrombosis. These patients used to present, had settled disease in the earlier, had settled COVID-19 disease, but then they directly presented with peripheral vascular gangrene. So their COVID-19 disease was settled, because of which it did not get diagnosed in time, and therefore the patients did not have the adequate anti-thrombotic treatment, and therefore they developed thrombosis in the bigger arteries, and therefore they got gangrene. So gangrene was also one of the emergency which was seen in COVID-19 scenario. Then pregnancy-related challenges were very, very significant. Pregnant women in the second trimester, in the first trimester or in the third trimester was easier to manage, but in the second trimester it was very, very difficult because we could not do imaging that frequently, and they used to present with hypoxia, tachypnea, tachycardia. Their intra-abdominal pressure was elevated. Non-invasive ventilation is actually that was relatively contraindicated in pregnancy-related pregnancies, but because of their severe hypoxia, we used to take consent and then start with related oxygen therapy. We used to avoid non-invasive ventilation as much as possible, but when there was no alternative, then we used to give non-invasive ventilation. Very few people, but somehow pregnant ladies did much better than expected. Actually, the final outcome of these pregnancy-related complications, when remdesivir was actually relatively contraindicated in pregnancy, we used to take consent that we are giving this as a life-saving measure in pregnancy-related complications. Their X-ray used to be very highly, the severity score used to be very high. The disease used to be very aggressive, but somehow I don't know, because of pregnancy-related immunity boost or what, but the prognosis was relatively better in the severe disease of pregnancy, and most of them did very well. Very few patients did not or succumb to COVID-19 pregnancy with COVID-19. Then macrophage activation syndrome, they used to present very high grade fever. These patients used to come majority from the periphery. They already had received a lot of therapy before their diagnosis was done in time. Their treatment was done in time. The treatment response was also not that good, and they used to land up in the emergencies with macrophage activation syndrome, all complications, sometimes hemorrhage, majority times high grade fever with shock. And of course, there were secondary infection in emergency, say with acute red eye. Then mucormycosis was one of the major with sinusitis and tooth pain. They used to present in that particular scenario. Then there was acute CMV infection, which was seen in more as GI bleeds. GI bleed was major challenge because in the COVID-19 scenario, availability of endoscopy and availability of the specialist doing endoscopy was also very. I mean, the guidelines were such that we could not use endoscopy that easily as we do for other cases, or we used to do earlier. And GI bleed was used to be very massive. Then diagnostic abilities were quite limited, but somehow because with the adequate therapy, then diagnosis of CMV related ulcers was that way is a bit rare, but because of COVID-19, we had to differentiate, or our understanding grew, and therefore the diagnosis of CMV related GI bleed came up in the multiple diagnosis of GI bleed. Then there were other emergencies also which were being. Sorry, is anybody's mic on? Hello? Hello? Am I audible?
Hello.
Hello?
Yes, sir.
Am I audible?
Yes, sir.
Okay. Then there were other emergencies also which came like anaphylaxis. Then somebody used to, few people, they reacted to the antiviral drugs in a very unexpected way. There were renal complications also. renal complications were that ways unexpectedly bit low. Then there were hepatic complications also. So overall, COVID-19 in medical emergencies, there were lot of challenges, and the main challenge was in March, April, May, was that we did not know how to approach this patient, because with the PP kit on, with PP gloves continuously on, checking temperature was a challenge. We could not use the regular thermometer. Then this thermometer used to give very abnormal readings. It was not that accurate. Then putting IV, starting injections, everything with PP kit was very, very difficult. Then intubating such patients was a big challenge. We did not know, because of multiple screens and fogging, visual ability had gone down. So intubating was very difficult. We used to require more manpower to intubate such patients, and emergency intubation was very, very difficult unless the patient was unconscious. So all these medical then diagnostic facilities were also very, very had to use very sparingly, because the hospitals were not aware as to how much to expose these patients. Like a patient with acute myocardial infarction before COVID used to go to the cath lab directly and undergo a primary coronary intervention. But in COVID scenario, we did not know what level of uh, barriers or what level of cleanliness, hello, what level of barriers or what level of protection needs to be put for these kind of patients. So therefore, it was a huge challenge to tackle, especially the vascular events. And same used to apply with the operation theaters, CT scans. So these challenges were there in tackling these kind of emergencies. So this was about the medical emergencies. Then we go to the other emergencies. Next slide, please. Which were there, and they caused a major impact in the patient management, which was there. And these administrative, second important emergencies which came to us was the administrative emergency. First emergency was there that we should not treat these patients. We should refer them to government hospitals or the centers which were recognized for treating COVID-19 patients. So the permission to treat these patients was also sought by all of us who have been working in the IMA, and all of us went and requested them that how can we refuse the patients who are on our follow for years together or were known to us, and these patients who used to come with hypoxia to our hospitals and clinics had to be referred to uh, higher centers, and there used to be no place. So the first emergency meeting which we had with the administration was to give us permission to treat. Then there were a lot of plethora of guidelines, right, from WHO to the state government and the primary, so Pune Municipal Corporation COVID-19 Task Force. They used to send guidelines which were contradictory to for the private practitioner. And first of all, there was fear to treat. On top of it, there was a lot of confusion. So guidelines and guidelines related emergencies was a big problem. Which drugs to use, which drugs not to use, and how to acquire them for an emergency patient was a very, very big challenge which we were facing in the earlier part of the pandemic. In the later part of the pandemic, again, there was a huge confusion and the scarcity of medicines, which caused a lot of emergencies. And thereafter, it was a big challenge to treat these kind of patients. Reporting every patient which we were treating had to be reported to the primary this PMC portal, and the reporting was very, very elaborate and had to be done on a very frequent basis. So we had to report 8 hourly all parameters of temperature, all vital parameters, then all treatment which was going on, and all investigations, important investigations. So every 8 hourly we had to report all these things with a, so we had to employ a separate person to report all these things to the PMC. So 8 hourly for all patients. Suppose there were 20 IPD patients, all 20 IPD patients, we had to report 8 hourly. So that was a very big emergency for which we found that the solution is was to employ a person who used to sit only, the person's only duty was to keep on reporting all the parameters to PMC on the PMC port. Then we used to get notices. Administration used to send notices that we are supposed to use only this much oxygen on patients. So it was very difficult for a patient, or we had no, I mean, the oxygen parameters and the rationing of oxygen on patients was totally unheard of, and this was totally unexpected decision which was further taken off. So if a patient has got a oxygen level of 85, then we were told that we are supposed to give only 2 to 3 liters of oxygen. But these kind of rules were not accepted by the people who are already admitted. They used to say, "I am feeling breathless. Why are we not giving a sufficient amount of oxygen?" Then there were other emergencies of rationing of drugs. Again, the same thing, because of rationing of drugs, and our people used to go and sit in front of the commissioner, this collector office. Then they used to get the permission. Today, about, say, out of the 100 patients admitted, only 25 used to get remdesivir, and rest of the 75 used to just wait for their turn on the next day. So again, one more day, important day, used to get lost in the treating these kind of patients. Shortages were there for other drugs such as tocilizumab. Though every day, the maximum number of emergencies we used to face were added up. Every day we used to get a new emergency to face. Now today, suppose we were treating, say, 20 patients, and all were sort of responding to treatment. We used to get a new rule, because of which the treatment modalities which were using for those patients used to get suddenly rationed, and there used to be shortage. And then there used to be huge chaos in the hospitals. And in the peak period, where we were treating patients in outpatient department also, at that time oxygen went short. And this happened in the first wave also, in the second wave also. We were not aware, and we were taken totally off guard. Whereas, because of oxygen, electricity, this has to be uninterrupted. If you have kept a patient on HFNO, or if you have kept a patient on non-invasive ventilator, it consumes a lot of oxygen. And if that suddenly becomes short, that becomes a very major emergency. And that can lead to bradycardian arrest within few minutes. So if you have a patient on non-invasive ventilation and suddenly oxygen level drops in the entire hospital because of central supply, you are helpless and standing in front of patient. Even intubating that patient is of very less use, because you cannot ventilate that patient, and that becomes a very major emergency which cannot be sorted out. What we did was, we had kept oxygen cylinders as jumbo cylinders as standby in every hospital, in the ICUs. If the central oxygen supply goes down, we used to start them on jumbo oxygen cylinder with whatever oxygen they used to get. And that used to be a very, very major challenge and major emergency, right? This tackling an emergency where the patient is standing in your emergency department is easy, but tackling an emergency of shortages of oxygen in IPD patient becomes a huge challenge, where the patients are actually waiting outside. Another thing which we observed over here is, in IPD patients, there used to be a lot of pneumothorax and pneumomediastinum. This was much more than expected in the, this happened much more in the second wave rather than first wave. And pneumomediastinum caused a major problem, and with pneumothorax with surgical emphysema, especially of patients who had prolonged non-invasive ventilation. It was probably barotrauma, or because of weak lungs, we are not sure, because we could not do their imaging to that extent. But that is to cause a lot of challenge and emergencies. Then the challenge of audits of the patients who had already got discharged, and billing used to be a challenge UMC used to ask for refunds, and then the hospital administration used to ask us why this was used, why this was not used. It used to be a major trouble and emergency for us to handle these kind of situations. Next slide, please.
One minute.
Yes, yes.
Just a minute.
So overall, the administrative challenges or the administrative emergencies mixed with medical emergencies, mixed with other emergencies such as I want place, my patient should get priority, then police intervention, at why these patients were shifted. Next slide, please.
Just one sec. It is not.
Shifting,
Next slide.
sorry, shifting the patients to the next center. All these kind of scenarios used to be continuous stress to all hospital owners and all people who were working in the COVID-19 scenario. Continuous stress used to be there because that was total change in the protocol of COVID-19 patients. Right from admission to cremation, the total protocol was different, and we did not get any chance to adapt to that protocol in the early phase. Like, it was not part of our curriculum. Plus, this change in scenario of quarantine and this change in application of this protocol, it took a lot of time. Therefore, along with medical emergencies, we had to handle a lot of administrative, political, legal, social, financial, and all. We had crunch on all sides of all aspects of our social existence in this particular period. So next was our, is the slide going to come?
No, sir.
Okay.
So many slides were there, sir.
Really?
Yes, sir.
Okay. But I think I had sent the entire thing. Okay, I'll go. Shall I start sharing screen?
Yes, sir.
Okay, just give me a minute.
Okay, sir. Can I submit up to slide pattern? सर होत आहेत का स्लाइड्स शेअर करू शकता
I think if you can just put on the first slide, I'll
Yes.
talk on based on that.
फर्स्ट स्लाइड ओके सर 1 minute, sir.
Yeah. I think during the transfer, they must have dropped up.
Yeah, we got only so many slides.
Okay. So overall, in the last 1.5 years, all those who are working in COVID, they had a lot of stress because of the social scenario, the fright about COVID-19 disease, the initial presentation, the lack of knowledge, the norms of quarantine, the administrative challenges, the political challenges, social scenario. Uh, yeah, just keep this slide on.
Yes, sir.
Next was the infrastructural emergencies. All the hospitals who had got COVID permissions or permission to treat these COVID patients, all these hospitals, they had to do a lot, significant amount of infrastructural changes. All those who did not have central oxygen had to start central oxygen services first. Then they had to arrange for separate entrance and entrances and uh, exits for COVID and non-COVID cases. Then which had to be done in an emergency. Then third was acquisition of PPE kits and retain of sufficient amount of PPE kits. Then donning, doffing facilities had to be made. Then facilities related which were required in COVID positive patients, but were common for both, such as CT scan, then ultrasound facilities, and other lab related facilities had to be also arranged in an emergency, because the workload was very high, patients demand was very high, and we had to supply it a very it was a difficult proposition to keep a parallel system to in the same campus. So that was a very major challenge, and but our hospitals, they coped up. Our colleagues, they all came up with their solutions, and we were able to handle these emergencies. Because unless we had that, suppose we have to do we have a patient who has tachypnea and has hypoxia, and we want to know what is the PA pressure. Unless we get the 2D echo done, we were not able to ascertain whether how to treat this kind of patients, because this disease is unique, as it causes a lot of pulmonary hypertension, which was not seen in the earlier patients or in the earlier pulmonary edema cases. So pulmonary thrombosis and pulmonary hypertension had to be differentiated with diabetic ketoacidosis in a breathless patient, or ARDS also. So PA pressure accumulation needed 2D echo, or all these needed 2D echo. And for 2D doing 2D echo, we have to have a cardiologist, and those cardiologists had to be got to the hospital at odd hours wearing PPE kits, but all of them complied, and all of them that's why how we were able to tackle these emergencies in a very so this was an example of how infrastructure related upbringing, infrastructure related adjustments were necessary in this situation. Political scenario, right from the central government up to the uh, local government, everybody was so confused about how to tackle this particular pandemic, and every day there used to be direct press releases causing uh, lockdowns or different what do you say, restrictions of use, and this affected the movement of our staff from one place. Now going from initially were showing iCards, but not everybody related to hospital services was uh, being was given an iCard. Like suppose they had people who were supplying stents to the hospital, who are actually an active part of the system, but unless they cannot be given an iCard from the hospital side, but they are very important for doing an angioplasty of a patient who had presented with thrombosis or having acute myocardial infarction. So these kind of situation, they used to get stranded, because the material used to get stranded because the police did not allow them to come to the hospital, because they thought that it was not necessary for them to come out of the houses. Political scenario, caused a lot of turmoil because of different decisions which were taken, and these decisions which were taken without the without the opinion of the frontline workers. We had always suggested that from the central government level, all those till the local level, all the committees should have member of IMA, member of Association of Physicians of India (API), and member of ISCCM as their advisors, because then our feedback used to would have been easier for us to give a feedback about how the frontline workers are facing the situation. But this was never approved. Therefore, all decisions which were taken based on Western literature and with the consent of scientists who were not having a first-hand information about what is going on in the field. So, because of that, this political scenario or these decisions which were taken, they used to lead to emergency situations, and then the patient management used to get converted into emergency. For example, if we have to shift a patient from earlier, patient used to get shifted from various districts to Pune very easily. At least 2 to 3 patients in a day used to get shifted from various districts around in my day-to-day practice. But this had to be totally curtailed, and we started telling people that you stay wherever you are in that particular scenario. Don't try to shift to Pune, because it will be a futile effort and the patient will not reach Pune in a healthy state, because oxygen used to be a challenge, cardiac ambulance used to be a challenge, then traversing all the way to Pune and traveling all the way to Pune, and there was no vacancy in this hospital. So politically, all these decisions which were made, they affected the transport of the patient from one place to other. Then oxygen supply is to be a big challenge, and third is availability of vacancy in this hospital, as well as the availability of ambulances to travel this from one place to other. All led to emergency situations, and we were stranded with the patient in this situation. Then legally, we were not sure what is going to be the scenario. Then if we admit the patient and there is to be unfortunate event, we were not sure what is going to be the reaction of the legal or the relatives, whether they are going to be legal action on us, or legally what is our immunity as far as Pandemic and Epidemic Act is concerned. So that was a very big emergency, and it caused a lot of stress to patients, to the doctors who were treating. Is this disease was new, the pathology was being slowly understood, and before that patient has succumbed, there was no postmortem, or there was no regular legal process which was applied to this particular scenario. Suppose somebody goes to the court, what will be our immunity to treat this, or to help these patients in managing or in treating COVID-19 patients, was totally unclear. But second legal issue, which was very difficult to digest or may have led to emergencies, patients who were COVID negative and admitted in the hospital, if they got COVID infection because of and they claim that it is because of not because of the society, and they claim that it was only because of the hospital, then what process should be followed, and what standards should be displayed to prove that this hospital has followed, or this infection has occurred despite following all standard protocols, was not particularly clear. Therefore, that was a situation where we were quite stuck. PCR report used to take initially 12 hours to 24 hours. Then during the peak period, it used to take 72 hours to get the PCR report. Till then, where to keep the patient? Most of the stress or most of the emergency situations, they occurred because of that. Patient used to land up in the emergency, and we were not sure whether to keep them in the isolation ward or whether to keep them in the regular ward, because PCR report is to be pending. So patients were absolutely resistant to go to the isolation ward. As soon as they used to go to the isolation ward, because there were no relatives associated along with the patient, they used to start saying that I have been admitted here for no reason, and there used to be a lot of stress and threats of taking legal action against us in this particular scenario. Then there was the social angle. Most of the patients, they were resistant or defiant, or they did not want to get treated or in the hospital was because of the quarantine. They people used to feel isolated in our social setup, in especially in Indian setup. It is very difficult to convince patient to get treatment in the isolation wards. Second, in the isolation ward, the manpower allocation used to be very low, because most of the people who were allocated in the isolation ward were selected uh, as by the hospital as those who did not have any comorbidities, who did not have any illnesses. These patients were rotated in the ISO ward. So the number of people working in the isolation ward was at least was lesser than those working in the regular hospital section. So these people did not get service as effectively. Suppose somebody wanted a urine pot, somebody wanted to go to the toilet, and they were hypoxic patients. So helping them going to the toilet also was very difficult. Majority of these patients, they suffered after going to the toilet, or uh, they had an accident while going to the toilet and coming back. They fell down in the toilet and had arrhythmias. So this was a very major emergency, and that was a very big challenge. In big hospitals like Sasun, where I had gone for the rotational duty, the toilet was so far from the bed. So we used to accompany the patient going to the toilet, and then we used to come back and settle that patient, because the patient, as soon as going was going to the toilet, he used to remove the mask. He used to go to the toilet and come back with the oxygen level of 60, 70. Second important factor was, while having food also, the patient used to develop severe hypoxia. So I had, in fact, instructed everybody to keep the mask on while chewing the bolus. Just remove the mask, have the bolus of food, and keep the mask on. Then that used to help the patient to maintain the oxygen level, because oxygen level, maintaining oxygen level in COVID-19 is a very big challenge, because the oxygen requirement is very high, and the pulmonary thrombosis which occurs, it causes a significant hypoxia as well as hypercapnia. Financial issue was, emergency was a very huge problem for especially the COVID-19 patients, because the bank's transaction used to be closed. There used to be lockdown. They had the money in the bank, but there was limitation of transfer to the hospitals, or wherever they wanted the money to be utilized, or pharmacy, or wherever they wanted the essential services. It was a huge emergency situation. People did not have that much amount of cash. Even doctors were stranded. The hospital owners were also stranded, because they wanted to pay the vendors. Vendor payment used to also get delayed. Then there was a limitation of billing. Plus, there was the expenditures did not go down. Neither the electricity bill went down, neither the property tax went down, neither the salaries. In fact, salaries had doubled. All the staff who was working in the COVID-19 scenario got double salary, because they were taking risk of life. So they charged double to the hospital owners. And because they charged double to the hospital owners, and on one side, and other side, there was no financial uh, gain because of sealing and audits from the patient. Hospital owners were totally stranded, and frontline workers were getting totally stuck. On top of that, the savings had eroded in the first lockdown. Majority of the healthcare workers' saving were utilized in the first lockdown. So in the second lockdown, there was a big financial crunch. So overall, in the past 1.5 years, right from going to work, like transport, till coming back home, and taking care that our families don't suffer because of infection, because of our professional thing. All of these were huge challenges and all emergencies. Everybody who has worked in the front line, their phones were continuously on. I used to receive 500 to 600 calls every day, and attending all those calls were totally, the calls used to come as acute emergency, then availability of drugs, availability of place, availability of all essential commodities. Any call, next call, you used to be very I mean, every call used to be a different challenge altogether, and it was a very tough time for all of us to, by God's grace and by cooperation from everybody, we were able to handle all these emergencies. Every call was emergency, no call was for any other work. And we were able to handle all this situation with everybody's cooperation. I again thank IMA. They have been very active in this pandemic. Every time there used to be a problem, we used to call IMA members and we used to have a meeting. We had a direct dialogue with all administrative people. Then we had dialogue with the mayors, the representatives of different political parties, and all associations. They also came together, and because of which we were able to handle this situation. Otherwise the situation would have been much worse, and I really pray that we don't get this third wave. And I have been talking to the people, educating about them about using the mask and avoiding unnecessary travel as much as possible. But there is a limited success to that, as people don't feel that it is that essential. But I still feel that if we all stay together as we are doing, we will be able to handle these waves as effectively as we have been able to handle the earlier waves. There are certain things which we have already made preparation, and for the third wave, which we had not done for the second wave, especially availability of home-based oxygen therapy has been put on priority, and patients who don't get place, like for at least 10 to 12 hours, we should be able to manage people at home. This kind of arrangements we are making so that they don't get stranded and hypoxic in the casualties, or they don't get hypoxic in the ambulances, and they don't get complicated on that way. So I hope my talk was of help. Actually, this was a very heart related topic. I mean, we have been all, I'm talking out of my heart because of our experiences in the past 1.5 years. Therefore, it may appear, and I'm sorry for the slides. I don't know what happened, but a few of the slides were missing. I would like to have any questions if there are any, and otherwise I would like to stop here.
Thank you, sir. Uh, Thank you for your all experience talk. With sir's vast clinical experience of handling COVID patients in ICUs for this 1.5 year, he has discussed not only medical emergencies but also administrative, political, infrastructure, social, legal, financial, and many other challenges while treating COVID patients. Thank you very much, sir, for your all elaborative lecture. I request Dr. B.L. Deshmukh, sir, to felicitate you, our president.
Thank you, sir. Thank you.
This is bouquet for you.
Felicitation. Thank you, sir. Thank you.
This is Uparne for you. I am Uparne for you.
Thank you. Thank you.
The next lecture is by Dr. Pratibha Kane. Her lecture is on consent and documentation. Just now, our all the speakers, they have told about the consent, proper consent, and the exact documentation should be kept ready. So we will listen to our madam, Dr. Pratibha Kane, on this. She's a HOD anesthesiology, Jahangir Hospital, Pune, and she's got an experience of 34 years. She's a past president of ISA Pune City. She's a postgraduate teacher, DNB anesthesiology since June 1997. She's got a special interest in neuroanesthesia, medico-legal counseling, and healthcare communications and training. So, Madam will be discussing this very important topic, consent and documentation. So, over to Madam. Welcome, Madam. Madam, unmute yourself.
Yeah. Shall I share my screen? Can you hear me?
Yes, yes, Madam.
Can you see my slides, please?
Yes, Madam. You can start.
No, there's some problem with the. Is my screen?
Yes,
seen?
yes, Madam. Yes, Madam. Yes.
All right. So I thank the IMA for this invitation to present documentation and consent related to COVID-19. I salute all the COVID-19 warriors, and I hope this presentation will be of some use to you even in the future. So we doctors are really going through one of the most testing and difficult periods of our practice. Our sacrifice, overwork, stress at managing a new disease has not gained much appreciation or sympathy. Instead, we are bearing the brunt of lack of resources, beds, ventilators, oxygen, even drugs. The pandemic has not given doctors any legal immunity from litigation. At the same time, society suffering from the fallout of alleged substandard treatment, poor outcome, black marketing, and overcharging is angry, and litigation is expected to skyrocket. They have 2 years to file complaints under the CPA 2019, and the only shield we have in our defense when the case comes up for hearing is our documents, including consent. So what we need to have, actually COVID-19 is a peculiar infection in the fact that for the last 18 months, the signs, symptoms, investigations, treatment, guidelines, they're all in the public domain. Treatment is constantly changing. Controversies have been highlighted and discussed in the media at length. Why should X-ray be done versus HRCT? Should antivirals be given, not given? What are the doses of steroids? When should they be given? Deficiencies in documents are going to be easy to detect because everybody has become an expert. So what we need are court-centric documentation, which allows easy recreation of events and responses, a true reflection of the facts, findings in real time, clear reasons for decision-making, for actions taken, not taken, and any ongoing outcome. More detailing, better the defense. Emergency situations should be evident, critical events obvious, use scientific language, but avoid abbreviations or jargon. Excuses of hurry, many serious patients, or overwork are unlikely to be accepted. So let's see what Dr. Joshi was talking about. This was what we called a COVID consent. So this was taken by healthcare institutions when the community infection was low and it said that I understand that I may get COVID during hospitalization in spite of all precautions. And this was thought to be inappropriate because the patient cannot consent to get COVID. And it was also thought inappropriate to write that I will not hold the hospital or doctor responsible because he cannot sign away his rights. But I need everybody to understand that since now it is difficult to pinpoint the source of infection in a pandemic, we do enjoy a partial immunity. So this COVID consent can become now an information leaflet, a reminder or a warning for everyone to take appropriate measures like mask and distancing, even while getting treated for other disorders, as this is a high-risk area for COVID infection. Documentation for consultation in COVID era must start with patient identity and age verified by the Aadhaar card. We need to have at least 2 to 3 emergency contact numbers. And the next, I think, is going to be very important for everybody or all doctors is to design a patient declaration of COVID exposure. I would call this a COVID footprint because the past infections, tests, dates, reports, treatment, whether at home or in admission, severity, treatment received, discharge card, exposure, death of near relatives, travel history, present symptoms, even vaccination history is going to be critical for us to diagnose COVID or non-COVID, post-COVID or long COVID. In admitted patients, the progress sheets are extremely difficult to write or type correctly in PPEs, as Dr. Aniket said. What we use is pre-printed sheets with cues to avoid missing any entry of symptoms, vital signs, imaging, and investigation. We use severity scores and COVID markers for decision-making, especially for decisions using drugs. Institutional protocols must be based on government guidelines. All early warning signs have to be recorded at least 3 times a day, and there must be 1 consultant review per day. Relative information or talking to the relative should be done by a decision maker for them to feel that somebody is looking after their patient. They must be given a clear understanding about complications and sudden turn of events, which they could be cardiac, pulmonary, or neurologic. There has to be a daily notification to government authorities, and all our sheets must have a comment section to record reasons for deviations from protocols. So we must make notes to jog our memory and recreate the situation and make it very obvious for lawyers to understand the standard of care. For example, GA was given and spinal was not given because patient was drowsy. Injection remdesivir was not given today because it was not available for the last 3 days. Why X-ray was done and not the HRCT? Why the patient was refused admission because ventilator was not available, and the patient was transferred to another hospital because relatives demanded so. How to document critical events is usually a very valid question, and the answer is as soon as possible. Documents must reflect a continuous monitoring. Most of our monitors give printouts of critical events if taken within 24 hours. These are very easy to understand: the arrhythmias, the cardiac arrest, and responses to CPR. No consent is required for emergency ventilation. The use of remdesivir must be according to guidelines which were given on the 7th of last month. Tocilizumab use we must write some rationale for its use. We must record end of life options whenever they are given. And there is a serious concern about advising new technologies in COVID-19 treatment. Now, Dr. Trika from AIMS has said that extreme caution must be taken when advising for ECMO, for lung transplants as life-saving treatments. They have a mortality of 80 to 100% in our country, and hapless relatives are made to run from pillar to post, wasting resources on some false hope. There are certain guidelines which have been given, and if you don't follow these guidelines, it can cause great bitterness and conflict. Discharge summaries must have detailed medication schedule. They must warn of post-COVID or long COVID, and there must be some advice to seek early treatment. Transfer to other hospitals, the documentations must be of the reason and the time. We have to take responsibility for transfer, arrange well-equipped ambulance without delay, hand over all investigations, inform a brief summary to the receiving doctor, and create some goodwill. Teleconsultation is a landmine of legal liability, and we must all follow the March 2020 guidelines for telemedicine. Patient identity and age are to be confirmed. Specific consent from the patient is required for agreement for teleconsultation. It can be audio, video, or chat. If the patient initiates a call, it is accepted as an implied consent, but a specific consent is required for recording the consultation and its use in case of any dispute. The digital platform used must ensure patient privacy. Quickly gauge the seriousness of the medical problem and advise physical consultation if one feels so. Now, prescriptions should be a scan or a photo of your normal prescription and only of the list or drugs which are given in the guidelines. There are certain restrictions on list A and list B drugs, so we need to know about those. The prohibited medicines cannot be given on teleconsultation. We have to all understand the limitations. Internet, poor connectivity can cause misunderstanding, and understand that there is a serious potential for its misuse in social media, causing breach of confidentiality. Now, discrepancies related to certification of death for COVID-19 patients are flooding the High Court. We have to follow the WHO and the ICMR guidelines for MCCD. It is extremely important for epidemiological classification, and wrong cause of death causes hardship in application for insurance claims and compensations in COVID relief schemes. The Supreme Court has asked the government to simplify COVID-19 deaths certification process. And in response, on 21st of June 2021, the center has mandated that any death resulting from COVID-19 shall have to be so certified, that is, as COVID-19 death, failing which everyone responsible, including the certifying doctor, shall be responsible for penal consequences under IPC section 188. The exceptions for certifying COVID-19 death at present is where it is an incidental finding in accidental trauma, poisoning, and acute myocardial infarction. So a senior faculty should be involved in this crucial documentation. Hospital bills are documents of dispute. for alleged inflation of hospital bills, for overcharging, and for not strictly sticking to the revised rates, which are constantly being updated. So billing should be transparent and as reasonable as possible, and documentation of a periodic financial counseling is as important as clinical management. Now, consent in COVID-19 has really taken a sheer beating because we really don't know how to manage it. Normally, a consent is a permission given or an agreement made voluntarily by a competent patient with a particular doctor for a specific medical intervention. Here, the patient may not be competent because of disorientation, and so it is difficult for him to exercise his autonomy. Now, doctors are now working in teams, or so we don't know which doctor is going to be responsible. And also, there may be many medical interventions going on at the same time. In spite of that, consents have to be taken. What we are doing is we are taking pre-anesthesia checks for patients in isolation wards and ICUs by phone from residents or consultants who are managing them. Then we document why the adult patient has not signed, because either he was under the effect of sedation, or he was on an NIV, or he was being ventilated. I personally insist to see relatives and get them to sign physically for any major non-emergency surgeries for COVID. At the same time, location of relatives, whether they can physically come to the hospital or they are in quarantine, has to be mentioned. Information of risk is very, very difficult because there is so much of uncertainty, and there is a real serious risk of sudden life-threatening complications such as acute respiratory failure, myocarditis, seen even in mild cases. We've had code blue or cardiac arrest in patients who are actually being wheeled to the operation theater and seem otherwise stable. We have to mention in the consent form that there is up to 30% increase in morbidity and mortality in the perioperative period. If we have done any counseling for deferring of surgery, must also be mentioned. Consent for surgery in mucormycosis patients, we have to mention the high risk of perioperative complications, including death in almost 10% of these patients. We have to mention specifically in case there is going to be any deformity of face because of the surgery that is planned. Loss of vision or loss of eye must be separately mentioned. We also keep a record of counseling against surgery in old patients with CNS spread, with stroke, semi-consciousness, and septicemia, especially when it's going to be a waste of resources for this patient who is certainly going to land up on a ventilator with a very, very poor prognosis. We have to take a consent for vaccination, and the state actually had to drop written consents because of the alarmist information. This is the news in January 2021, where the healthcare personnel themselves were hesitant to take vaccine because of this alarmist information. This fact must really be considered by lawyers and judges before insisting on a fully informed consent. In an emergency, a consent is not required to save life and limb, to stabilize a patient, to prevent deterioration, or to transfer the patient to a higher center. Operating in good faith is acceptable without a consent because human life is more important than legal formalities. though every attempt must be made to locate relatives and to explain the situation. We must document all communication and counseling. So all interaction with patients and relatives must be documented, especially when treating children. Facts that were discussed have to be noted. So let me conclude by saying that COVID or non-COVID situations, improper consent and improper documentation are going to remain the two giant killers for medical negligence in court cases. And on the brink of the third COVID wave, let us ensure that our documents will stand legal scrutiny in the years to come. And let us create a formidable evidence of a high standard of care, which is the only thing which will protect us from the inevitable tsunami of litigation. Stay safe and thank you.
Thank you, madam. Thank you for explaining us the importance of documentation and consent even in this COVID era. I request our President Dr. B.L. Deshmukh sir to felicitate Kane madam.
Madam, this is bouquet for you.
Thank you, sir. Thank you very much.
Madam, this is our Upparna, brand of IMA Pune.
Thank you, sir.
Thank you.
Question answer will be
Okay. The question answers will be taken after the talk by Dr. Naurange sir. Final talk by Dr. Naurange sir. This is our last talk. I request Naurange sir to give this talk on important judgments. I don't need to introduce Naurange sir because he's already been introduced, and all of us, we know how much work Dr. Naurange sir has done in this medical legal field, and we are very fortunate to have him on the side of doctors when there is any problem regarding medical legal issues. I request Naurange sir to take over.
Thank you, Dr. Ingle. And just hold on for a moment. Yeah. शेअर झालंय ना. I hope the slides are visible.
Yes, sir, we can see the slides.
You can see the slide. Thank you. Thank you, Dr. Ingle, for giving me an opportunity to share my views once again. And we will be discussing some important landmark judgments. Of course, one or two have come even after that, which will make some difference in our way of practice. But we will be highlighting the cardinally important judgments and some of the salient features of the new what I would say notifications and laws also. So this will be my talk and this will be the last part of the program. At the end of the program, all questions will be answered by the respective faculty, and you are requested to post your questions on the question answer tab mark on this Zoom meeting. So afterwards the coordinator will be asking the questions, and one by one he will tell who's to answer and all that. Some of the questions are already answered by a written reply. With this, I start my presentation. The laws of interest for the medicals. So this is the thing which we should know primarily. All general laws like the Income Tax, the Vehicle Act, Trust Act, Partnership Act, these are all applicable as for a common man to doctors also. In short, there is no special exemption for doctor category. However, there are some additional responsibilities cast on doctors. One, as evidence to be laid down in other cases, and when number two, to defend our own cases. So these are the two aspects of laws of interest for the medicos. Laws are of two types to generally categorize them. One is substantive law, in which you have to understand a particular law, what does it intend to do, what changes they intend to make, and we have to act accordingly. So it's a matter of understanding in detail the principles of those acts. So they lay down the principles, and interpretation is very important. And examples of these are Indian Penal Code. So what is meant by actually an crime of, say, attack or assault or defamation, like that? That will be defined over there. Then there is Contract Act, because every consent comes under Contract Act, whether it is written or not. Evidence Act, Indian Evidence Act, in which we will talk about the expert evidence and all that. Consumer Act, already it is there, but it is a special variety of Civil Act, and that's modified in 2019. POXO Act, which is there from 2012, and you need to understand them well principally and understand it well, so that you can work under their respective premises. As far as procedural laws are concerned, they are more of a dictatorial type, in the sense that you have to follow these XYZ type, XYZ points. For example, Civil Procedure Code, it gives you or gives the person the definition where the suit will lie, in how many days it has to be filed. So there is a specificity in application of these laws. Criminal Procedure Code, again, if a crime is not registered within 3 months, and if it is registered, it is not further investigated in XYZ amount of time, does it lapse, and so on and so forth. So these types of matters are covered by these procedural laws. Biomedical waste disposal. So once they are passed, you have no argument over it, unless the respective chamber of house rectifies them as the days pass by. MTP Act is a very strict procedural law. Registration Act, you have to register yourself. I mean, there cannot be twos about it. Stamp Act, as per the tables given, you have to pay the stamp duty. So these are, in short, the procedural laws. Usually many laws are a variable mix of both these principles. This I think I have covered, so I will not be talking about criminal versus civil negligence. These are some of the laws which are in the offing, or some of them have already come into the existence. Bombay Nursing Home Act of 1949 has been modified in 2010 and is likely, I am still using the word likely, to be replaced by Clinical Establishment Act of 2010, already passed by Parliament, but not passed by the Maharashtra Assembly. Actually, in fact, luckily I would say for us, it is not even tabled in Vidhan Sabha and Vidhan Parishad. Mental Health Care Act of 2017, it is also quite a different act. So many changes are there, but in Maharashtra it is not yet implemented. To the best of my knowledge, there is some controversy about some of the parts and it is getting implemented. But by and large, it is not still in force. In Rajasthan, I am specifically highlighting this small act, but then it's going to be important in the future, that in April 2019, the assemblies have passed and assent of President has been obtained regarding the act to have the force of a law when we consider the right to health care. So this is already passed by Rajasthan, and one by one further states will pass it. National Medical Council Bill of 2018 has been passed as an act in 2019 and is very much applicable all across the country. HOTA, that is Transplant Act, is rather amended act, and very important one is the Consumer Protection Act of 2019 is completely replenished or replaced Act of 1986, which I will come to at the end, and Epidemic Act of 1897 with amendments of 2020, and that has been elaborated upon by Dr. Walke and Dr. Meenakshi. So this I will skip because all of us know that, this Consumer Protection Act of 2019 has 3 levels as usual: district level, state level, national level, but the amount where the case will go has been increased substantially. So district courts cases will tackle up to 1 crore. State level commission will tackle cases between 1 to 10 crores, and national commission will tackle the cases beyond 10 crores. However, there is one small but very important useful distinction for doctors, that previously it was this amount was the amount demanded by the patient as compensation. Now it is the amount of the bill. Either the bill has been paid, unpaid, or partially paid. So I think in majority of cases, the bills don't go beyond 1 crore, medical bills, and therefore all cases will lie in the district forum. Already this procedure has begun, that the cases from state level have been getting transferred to the district level. So it is a bit easier to defend, but there is one more which I will come to a little later. Limitation period is 2 years, and we come to summary procedure. It is there, advocate is not very much required, very small stamp duty. But the one important change which is detriment, one good change for doctors is this amount. But one bad thing for doctors is that the patient can put a complaint against us even from the patient's place of residence. So for super specialties it is more problematic, that somebody who is a super specialist working in Mumbai and Pune gets a patient from Assam or Kashmir, where he can lodge a complaint in those areas, which was not the case before. And to defend, you will have to defend in those areas. So ultimately, in short, I would say today that you will have to appoint or take help of certain agencies, which are offices, legal agencies, which are offices in all these states. So that will be a near future thing in reality. Secondly, e-commerce is added, and second, also complaints can be lodged from online by online method. So already we have seen there is a flooding of cases at MMC level once they have opened online registration of complaints, and similar case will be arising for the consumer commissions also. The next is MMC, NMC acts, and this everybody knows very well. Indian Penal Code, there is no major change but an important act. So I will skip these. And what is new? Now while coming to the newer aspects and which is going to affect everybody's practice is that as of today, take the help of this decision that Shop Act, which is amended in 2017 in Maharashtra, says that every establishment, including a clinic, needs to be registered under Shop Act who is employing less than 10. So below 10, even if it is a hospital, Shop Act registration is not required. So this is a very big change. So, but then there is one small thing to be done, that we have to intimate to an authority called as facilitator online through Shop Act portal, that you just say that I am running such and such profession, I got these people employed, and this is their salary, and this is their I card, that is your Aadhaar card number, and that is more than enough. Whenever there is a change in the staffing, you you inform them. However, government has still not appointed the position of facilitator. So this is to our benefit, but then I discussed the matter with labor court people and labor court advocates, and they said that you just inform this information instead of facilitator to the undersecretary of the employment and Shop Act department. So this is one small thing. Usually we are having small nursing home or small clinics where the number will be less than 10. Shop Act registration is not required. You just inform this much to the undersecretary of the Shop Act department. Anti-cut law was discussed, but it is probably ज्याला आपण म्हणतो बासनात गुंडाळून टाकलेला आहे. So it has not moved forward at all. Bond completion and release certificate for issue of renewal by MMC for those who have passed after 2010, it is required for MMC registration and renewals also. Supreme Court in 2018, I'm just giving some important judgments. I will not bombard you with one judgment after the other because otherwise it is impossible to remember. In writ by Delhi government and also Union of India versus Delhi High Court, two-judge bench of the Supreme Court in July 2018, the fine imposed by Delhi government against the trust hospitals who did not do charity to the extent which is mentioned, that is 10% and 20%, even if they got the government land concessionally or free, was negated by Delhi High Court and reversed by Supreme Court, which said, and this is पॉइंटर इज नॉट कनेक्टेड नाही हे हा आला काहीतरी लूज कनेक्शन होतं.
ते शेजारचं डिजिटल ते त्यांना काढायला सांगा, म्हणजे याच्यावर पण तुमची इकडचे अक्षर जातात.
May I request DigiShield? नाही पण इथेच गेलंय ना आपले. We are not able to see the complete text of projection. DigiShield, can you marginalize these?
Sir, clear it.
Sorry, sir, that's not from my end. I cannot do anything here. Please check your display settings on the top left.
सर दिसतंय सगळं व्यवस्थित आम्हाला.
आमच्या प्रोजेक्शन वर दिसत नाहीये at IMA itself.
हा पण
Okay,
आम्हाला दिसतंय.
ठीक आहे, go ahead. So, Supreme Court, I felt very sad about this judgment because they reminded us of the ethics. And what are these reminders? No refusal of treatment for poor patients in dire need for any medicine, modality of treatment or any expert. There has to be balancing between human rights and commercial gains. Constitutional obligations to treat the poor is there of the government, so it has to be shared by the private hospitals also. Dark side of such hospitals can be eliminated only by sharing obligation towards economically weaker. These are the words of the Supreme Court. So Delhi government directives were upheld. So when we see such type of directives or the wordings, it is a stark reminder that even judiciary is probably not going to help the doctors when it comes to money matters. So this is just one side of the story I am telling, and this is from Supreme Court, so it is binding. They have overturned this Delhi High Court government in favor of the doctors and against the Delhi government directives, and this is how the terrible commentary has come from Supreme Court just 3 years back or 2.5 years back in 2018. Now, second is various state governments are passing various clinical establishment acts after the parliament has passed it, and Karnataka Clinical Establishment Act, which was also draconian in November 2017, but the doctors remained very united and they had to go back for the time being. So, however, it has been upheld in West Bengal West Bengal state, and what does it mention? They have already passed it. They are implementing it. 3 convictions have occurred so far. 50,000 penalties and jail of 3 months has been done in 3 cases. What does it say? Compulsorily free service if the death has occurred of the patient. That is number 1. So you have to forego all the bill. Number 2, district grievance cell, which has powers to decide medical negligence. So this is one more body which is going to decide about negligence, and this is non-judicial. And award compensation in addition to the courts and imprison also. So one more forum you have to answer. This is not applicable for the government institutes. They have fixed the fees as fees at rupees 150, 100 and 50 only. That means 150 for the first consultation or visit, second consultation 100 and subsequently 50 only. Government will pay for the first 2 days in case of roadside accident, but it has remained silent who will pay for the remaining days. Repeated media harassment in many ways, illegal flakes, the latest MNS, that is Maharashtra Navanirman Sena hoardings. Any hospital deaths discussed on hoardings now. So we are threatened for breach of confidentiality, and here these boards themselves are breaching the confidentiality to the 100% extent. Another new thing, no ICU, don't do surgery. I mean, this is not uttered in so many words, but I will give this particular case. In 2017 September, a West Bengal case in 1993, hysterectomy was done. Patients did not come out of the general anesthesia, so therefore required a shift to ICU. In another institute, one more transfer occurred from that institute as the patients were not happy there. Right now, by the way, one more similar case is going on in Maharashtra in the district of Kolhapur. Same case, similar case. Patient went into brain death or some similar complication, transferred to another hospital in Kolhapur. They were not satisfied there, and the patient ultimately shifted to Mumbai at Ambani Hospital, Kokilaben Hospital, and the case is going on at multiple places. So So here the doctor was not negligent. The case went up to Supreme Court, and at the High Court level, the doctor was exonerated. Supreme Court also said that there is no negligence, but 5 lakhs compensation was awarded against the doctors in favor of the patient because it just had a passing mention that had there been an ICU, probably the patient would have recovered. And this case has, this point has not been tackled by previous two courts, and therefore we feel that justice, two ends of the justice would be better met, because uh, the case is quite prolonged from 1993 to 2017, that is 24 years. But is the doctor responsible for this delay? And when we said that there is no medical negligence, even then 5 lakhs are to be awarded. And this being a Supreme Court, you have no further go. So this is that sort of thing that indirectly it says that don't do surgery if you don't have an ICU. So duty doctors, also I will skip this further next judgment. So be generous on investigation. In one more judgment, and Delhi Consumer Forum and subsequently the High Courts have said that do not hesitate to advise and get the investigations done for want of money. Don't look at the patient's pocket. In short, be liberal about investigations, because in the courts, the same parties in the courts ask, why did you not do this investigation? So there is no escape saying that patient did not have money and therefore I did not ask them to go for CT scan, MRI, PET scan, etc. Don't do that. Be liberal. So this, what I am saying right now, is exactly contrary of teaching in the government hospitals, where we have learned that do the minimum investigations with the maximum management part. So let the money be saved for drug part or the surgical part. Now we come to the landmark judgments, and the previous judgments which I showed was just to emphasize how the winds are moving, how the winds are flowing. These are now the established judgments, and they are never challenged, and these are the law of the land made by the judges, what is called as obiter dicta. So obiter dicta are the Supreme Court pronounced judgments, and they become the law of the land unless they are changed by parliaments. So number one judgment, and this is quoted again and again, this is the judgment which I already referred to when I was talking about medical negligence, the famous Dr. L.B. Joshi versus Dr. Trimbak Bapu Gorbole. And here it says that there are 3 duties on the doctor: decide if he will undertake this case for the treatment. If he decides that he will treat this patient, what is the line of treatment after due diagnosis? That means after doing the physical examination, getting the history and coming to a tentative diagnosis, doing the appropriate investigations, and then to implement the decided treatment. Any breach in any of the 3 amounts to negligence. Anyone ready to give treatment is supposed to possess necessary skill, knowledge, qualification, and registration, which I already mentioned. 100% guarantee is not possible. So in the Supreme Court of India decision in the case of CBI Hyderabad versus K. Narayana Rao, it has, I given the quotation also, that professionals cannot be responsible for all that happens to go wrong. So this was regarding a legal case against a lawyer. The same is applicable for all other professionals. Guarantees or warranties are the words which are unethical in the profession, and especially for the medical professional. So don't use these words of guarantees and warranties, and patients cannot claim on this basis. This is a famous judgment of VP Shanta versus Indian Medical Association, Supreme Court judgment in 1995, because of which Consumer Act came to be applied to the medical professional, though expressly it is not mentioned that medical field comes under Consumer Act. Now, there are many views, or I would say sought loopholes by medical community and some experts. In the 2019 law also, in the Consumer Act, they have not mentioned about medical professionals being covered. However, I would remind you all that we are very much coming under Consumer Protection Act because of this judgment, VP Shanta versus IMA, because principles have not been overturned, number one. Number two, in section 1, subsection 4, it is clearly mentioned in 2019 that the exemptions are there only if there is an express exemption in the law or notification in the law, and which has not occurred for medical professional. So because it is not written, it is very much applicable. So it is good to buy some time, but I'm sure it is applicable to the doctors and the medical professionals. Ashwin Patel versus Poonam Verma, here 1994 judgment, which says that cross-pathy is not allowed. Now you know very well the present government and all successive government in Maharashtra, as well as the BJP government in in the center, is in very much favor of NMC. I mean, that was the sole reason to bring in NMC instead of MCI. That is my opinion. And they are of the opinion that other pathies should be allowed the cross-pathy to use allopathy to this extent, that extent, and the things are moving in that direction. There will be a bridge course and so on and so forth. And their moves are in those directions. आणि आपल्याकडे मराठीत म्हण आहे सत्तेपुढे शहाणपण नाही. त्यामुळे we are bound to lose all cases unless the high courts and supreme courts go in our favor. And here is the judgment which has been pronounced by Supreme Court, and there are many such judgments by the subsequent courts, that no cross-pathy is permissible. It is a primary negligence to use allopathy by an homeopath. That is the judgment. Ashwin Patel was a homeopath who used allopathic drugs correctly. I am telling you correctly, in correct doses and correct medication. And Jaslok Hospital gave the expert opinion in favor of this doctor. Even then the Supreme Court said that no, you cannot touch allopathy. But the things are changing. This was in 1994. Things are changing. Today we are awaiting some judgment in favor of this judgment or overturning this judgment. Right now, Indian Medical Association, Maharashtra State and Pune branch have filed a writ petition against cross-pathy in Bombay High Court. Supreme Court said that this should be decided by High Court as on a priority and urgent basis. And from 2000, I think 12 or 13 or 14, we are waiting for the judgment to come. So it is of no, I would say, express matter for the judiciary. Dr. Martin D'Souza versus Mohammad Ishfaq case, in which it has mentioned that consumer and criminal proceedings must obtain expert medical opinion, preferably from a government hospital, about the prima facie evidence that the doctor has erred. Doctor has made a prima facie negligence. No sensible professional, that is their wording, would intentionally commit an act of omission or commission resulting in harm to the patient. And professional is one of the professes, one who professes to have some special skill. And there has to be a different treatment in criminal law when we proceed against the doctors. With all this, extreme caution while accusing the doctors is needed, and therefore expert committee is required and no case should lie against them. However, this is partially, come to the last sentence, partially overturned by Nikhil Super Speciality Hospital judgment versus Dr. V. Krishna Rao in 2010. Martin D'Souza judgment came in 2009, and in 2010 this judgment says that if the case is something like res ipsa loquitur, which I said in the morning, obvious gross negligence, there is no need of an expert committee. But even today, majority of cases, the courts are insisting on expert committee report, or at least some expert report on part of the complainant. So that's a good thing for us. This Kusum Sharma versus Batra, almost the same conclusions as in Martin D'Souza's case, which has come in 2009, but then it was partially overturned in this V. Krishna Rao case, which I already mentioned. Now coming to another aspect is about the principle of vicarious liability. So I have explained this particular principle in morning session, first session, that whatever is done by your assistant, your colleague, your partner, your employer is primary responsibility of the main doctor, the employing doctor. This is of course in civil side only, that means in the consumer side. And I already elaborated about this Harjot Singh Ahluwalia. Now in this case, I'm going one step further. This was a 4-year-old child was being treated for typhoid with chloromycetin. Nurse wrongly wrote chloroquine. Lariago was dispensed. This was put into the IV tubing, and the patient became brain dead because he had cardiorespiratory arrest. And the compensation that time highest was 17.5 lakhs by the Supreme Court. Now coming to this point, I think Dr. Walke talked about hospital insurance, and it is very cheap and all that. So we should be taking two insurances in medical practice. One, for ourselves what is called as medical indemnity insurance professional. Second is hospital errors and omissions policy, and that is what he was referring to. And it is calculated on the number of beds, number of occupancy, and number of, average billing pattern. So in this case, once this pronouncement of judgment was there for 17.5 lakhs, the hospital, that is Spring Meadows Hospital, asked the insurance company to pay for the compensation. And as usual, insurance companies, this is my general remark, they are eager to collect the premium, but the last ones to settle the claims. Take it any company, no company is exception. Because there was one question in question answer box, chat box, that which is the best company and which is the cheapest. I answered that saying that at present, United Insurance is the cheapest insurance for medical indemnity. However, coming to settlement of claims, all are equally bad. So what this hospital was given a reply that we will not give this compensation because this nurse on duty was an unqualified nurse. But the hospital was smarter than the insurance company. And I want you to be smarter than the insurance company. That means all of us keep the untrained staff because they are not available and we can't afford it. You have to employ these unqualified staff also, but the insurance is available for them by paying 7.5% extra premium. So that 7.5% I would urge upon you to go ahead with this, because you are bound to employ unqualified staff and you will be protected if you take the insurance cover for the unqualified staff. And once this was pointed out to the Supreme Court, the case was finalized in 10 minutes. I am telling you, Supreme Court finalizing in 10 minutes is no joke. So it was finalized in 10 minutes and the insurance company was asked to pay this amount instantly. So this is one aspect. Second aspect is, whenever we are defending our cases in the courts, urge the court to make the insurance as co-party. So make them a co-party when fighting the cases of medical litigation. That is another point I want to bring, because this insurance company was not made a co-party. You have to pay the amount first and then look at the face of the insurance company and recover from them if at all you can. So be wiser by covering for your unqualified staff, and also become wiser by impleading them even at the outset when you start defending the case. 10 minutes more? Yeah. About consent, I think Dr. Pratibha Kane has covered it beautifully and adequately, and she must have covered this. I'm sorry that I had a call, so I was not attending the whole session, but she has covered this Samira Kohli's case, so I will skip this. Next point is this Sukumar versus Nilofar Hospital Supreme Court judgment in 2010, where a 14-year-old operated for mediastinal neurogenic tumor with intravertebral extension, which was realized on table and by a cardiothoracic surgeon. The question was, why only cardiothoracic surgeon was involved and why neurosurgeon was not involved. So this Nilofar Hospital is a state government hospital, a children's hospital, and did not consult, but actually the neurosurgeon was consulted, but he was not required or not requested to be present during surgery. This led to the paraplegia. Later the boy became BE-MBA and he fought his own case in the Supreme Court without appointing any lawyer. He was that intelligent. And this was, compensation was awarded as a special exemplary damages of 1 crore because a super specialist was not involved in such a difficult case. But then I went through the total judgment and it is not so. See, naturally the sympathy was towards the patient, but apart from that, the hospital tried to falsify the record by, see, in this particular neurogenic tumor, there was an erosion of one rib, which was there mentioned in the CT scan report. And whatever the evidence was submitted by the hospital, that means the medical authorities, that itself had clearly mentioned. So in defense, they had submitted certain textbooks as well as internet references. And in that they have mentioned that, I'm sorry, this was there in the X-rays, and in that those it was mentioned that you have to go ahead with the CT scan tomography if there is a slightest erosion, which they had not done. They had neglected this point, and therefore the courts were very angry, saying that you are giving us lots of evidence, but the evidence you have produced yourself mentions that what care you should take if there is an erosion, and therefore it was a point of negligence. So it is not what some of the medical legal experts at that time, including myself, said, that how can there be a punishment just because the neurosurgeon was not involved. It is because of this, that sort of falsifying the document. So never do that. Rashmi Fadnis case versus Mumbai Grahak Panchayat case, and this is a very old case of I think 1992, where the state commission that time had given the judgments that anesthetists are not involved directly and therefore a case does not lie against them, or pathologists. These are indirectly involved in the patient care. And this was a surprise judgment because then there would have been no case against the anesthetist. So this was overturned by the National Commission within 1 month. I remember this was one of the fastest judgments when it has gone in appeal. Even they have clearly mentioned that even anesthetists and pathologists and radiologists who are remotely involved in the case, they come into the picture because they are independent professionals. So that is no sort of immunity, that even if there is no privity of contract between the patient and anesthetist, patient and the pathologist, patient and the radiologist, because their opinions are sought by patient on the recommendation of doctor. So even if in the hospital laboratory is there, they give some report, something goes wrong, and doctor takes a defense that, oh, they could have gone to any other doctor. No, the radiologist cannot escape, the pathologist cannot escape, the anesthetist cannot escape, because they are independent professionals. So this is very important judgment. Next is Apollo Hospital versus Dr. X, and this is about confidentiality. So confidentiality rule is there. Medical ethics say that you should maintain the confidentiality. In this case, the confidentiality and secrecy is not an absolute right of the doctors. Even when it comes to danger to the human life by the non-disclosure, it will not prevail over the immunity under confidentiality. And so therefore it is not a privileged communication. In this case, AIDS was diagnosed in Apollo Hospital at Chennai, and the doctor who volunteered blood donation for that another patient, he was engaged with some spouse, and a marriage had not occurred. Somehow the spouse came to know from Calcutta, or I think Guwahati, that this doctor whom I am going to marry has already been detected as HIV positive in Apollo Hospital, Chennai, but the hospital was not giving any record. So she moved the court, and the court has given this judgment that this confidentiality is not an absolute right. So when it is endangering the other's life, it will not prevail. So you have to breach that particular confidentiality, not in an open way, but there are certain systems for that. This is Kunal Saha versus Dr. Mukherjee case and Amri Hospital, and this is the highest phenomenal compensation of 12 crores. And I think everybody of you know very well, this was a case of Stephen Johnson, and 5.5 crores was the compensation awarded to this Kunal Saha's wife, and 6 crores was the amount of interest on that 5.5 for delay, which is the delay. Judicial delay is definitely beyond the control of the doctors, and this case is partially getting fought, that why so much of compensation and why so much of interest penalty. So anyway, the principle they have applied is the reasonable foreseeability and giving significantly higher doses what are documented in the literature, medical literature. So therefore the patient died of the drug complications in addition to Stevens-Johnson syndrome, and this was a phenomenal compensation awarded. The case is still on, but I don't know what's going to happen in the revision petition. Management, and this is a common question asked in such seminars, is that I go to a particular hospital which is owned by a trust or a public limited company or a private limited company, and they take in writing down from me that in case the litigation occurs from my private patient, I will be solely responsible for the compensation, and that has never stood. Whatever MOUs, stamp paper agreements you do, it has never stood the test of judiciary. So always the hospital is a party for settling the compensation, usually to the extent of 60% and 40%. So 60% by the hospital, 40% by the consultant. There are very many legal principles, but I am just mentioning here that don't be afraid that the hospital is asking me to sign an MOU. Sign the MOU, sign the agreement, no problem. They will ask for even the uh, indemnity policy of 1 crore, 2 crores, depending on what sort of practice you follow. So that also you can give. You can give them a copy, but please be assured that hospital cannot get scotch free. Surrogacy, I think these are some of the small judgments, so I will not go in those details. There is no surrogacy law passed by the parliament as yet. There are only one discussion occurred when Mrs. She was there. So she had just notified, but it is on the principles of ICMR guidelines only. So the law is not passed. So I will just skip some of the judgments, and again cross-pathy, again there are judgments. Writ petition is going on by us. So whatever I told you already, is fetus an independent life? Answer is no. So this was discussed by a UK court and also by our court, that fetus, you should not take it as a live birth unless the live birth has really occurred. So their rights have no meaning whatsoever. Onus of proof, this I already mentioned, that onus of proof is on the complainant, who alleges what is the complaint, what is the negligence. They have to give the expert opinion, except in OT situations, in ICU situations, in labor rooms, where there is no free access to the relatives. The presumption is reverse in two situations. Now I would like to add one more over here, which is not there in the slide. PCPNDT, the presumption is that doctor is guilty unless proved otherwise. And number two, in cases of Epidemic Act, when the violence has occurred, the presumption is that people have created violence and they are criminals unless they prove themselves that they are not guilty. So these two situations exceptional. Of course, MOCA and Terrorist Act I'm not discussing. So these few situations where the presumption is that person is non-guilty. The onus of proof is on the patient and not on the doctor, except these three situations. PCPNDT, I think Madam has covered, so I will not cover anything about that. Laboratory report signing has to be done by a qualified pathologist. At least he should be diploma in clinical pathology, DCP, DNB, MD, and so on and so forth. It cannot be done by a technician, but still I am saying many reports signed by these technicians, which, be very careful, don't allow them, at least in your hospitals, at least in Maharashtra, don't do this. And of course, this is a Supreme Court judgment, so don't do anywhere in the country. Post-operative care, this is an important judgment, and the importance is mentioned. I mean, there is a regular judgment now from the National Commission. That's why I'm mentioning here, in case of Mrs. Sheila Hibra Naik versus Apollo Hospitals Limited, and undue. So this is already mentioned, that post-operative care is the prerogative of the hospital care. Undue referral is also penalized. Non-referral is also penalized. So both types of judgments are there. Violence Act, already there in our state government also, and that has been elaborated in by Dr. Walke. Homosexuality should be decriminalized is only an obiter dicta, but IPC still mentions it. Cross-pathy, I think we have covered it enough. Telephonic consultation, Dr. Pavaskar's case, all of you know very well that telephonic consultation was, I'm saying the use word no, was not allowed. But now with telemedicine, the rules have changed and it is very much legalized. So that particular judgment is for something else. That was about telephonic consultation and there was a negligence. To what extent? So what I'm saying about teleconsultation is that legal responsibility lies on you. You have to be extra cautious and don't rely totally on the legalization of telemedicine. The case is still going on. It is at the preliminary stage of primary hearing. FIR is already there, charge sheet is already there. So the case is getting fought at Ratnagiri level right now. Have these on your laptop or mobile. That is Maharashtra Prevention of Violence, Jacob Matthews judgment, Martin D'Souza, I did not mention much about Jacob Matthews, which stands a golden judgment for us even today, though Martin D'Souza is to some extent has been modified, but it is based on Martin D'Souza is based on the same principles of Jacob Matthews, that there should be an expert committee judgment. These are saviors for the doctors. So you have to keep them at the tip of your laptop and your fingers. These are already elaborately covered. And lastly, thank you very much that many more such cases are there. Be careful and watchful and not be at all relaxed. Always insure for 50 to 100 lakhs, I would say, for 2 crores now. Have updated registration with medical council, seek the help in time and not after submission of papers to any authority. Be a member of IMA and other professional bodies, but primarily of IMA because it encompasses all doctors, consultants, general practitioners, anipathy. So these other associations remain comparatively smaller. They are very active in their academics, but not working as a union, trade union. And IMA's role should be like a union, trade union, because they encompass all pathies, all doctors, all sorts of situations, and therefore primarily everybody should be a member of IMA. Unite and pray God. And previously we were asked the question often that what IMA is doing. I think the answer is adequately clear that not only we are helping each and every member, but even the non-members. And also we are fighting the cases in regular courts of law. So there is no more complaint that what IMA is doing. So with this, I request that unity is strength, and they all look at, I think Dr. Walke also mentioned that they look at it as the vote bank. So unless that is strong, your questions are not going to be solved. Thank you very much for patiently listening. And I request not to honor me again. Once we straightway go to the question answer. Yes. Dr. Ingle, please.
Yes. Thank you very much, sir. Thank you for giving us very important tips, medical legal tips, quoting the important Supreme Court judgments. Thank you very much for that. Now we will take some questions.
You can take this. 3 questions are there. Some already I answered. So.
I think सरांनी 2-3 already answer केले थे.
हाँ, केले ये 2 नवीन हैं. Sir, please provide the ideal consent format for OPD and IPD patients who have COVID-19 and who do not, so that future false allegations and legal chaos regarding hospital-acquired COVID-19 can be prevented, as many a times rapid test negative or asymptomatic patients later come positive and vice versa. I agree with you. I request Dr. Pratibha Kane madam to prepare a consent so she can do the work, and if you can send it to us in IMA, we will circulate to all the attendees at the earliest possible. We have general consent and we have absolutely updated consent forms, and I don't know whether madam knows about this, that we have prepared 2 additions, that this this consent should be in triplicate. It should be sent to the patients on email or provide 3 copies. They download themselves, print themselves. That is number 1. 1 copy they preserve themselves. 2 copies they bring while fixing the surgery after, of course, initial consultation. This is all in cold cases. For emergency, as you already mentioned, that no consent even is required. So forget about that. But this is for cold planned cases. And next point is that there should be a mention that I have been informed adequately, all my questions have been satisfactorily answered, and doctor has given me further reading material in the form of suggested common 3 website links like Mayo Clinic, which adequately deals with common questions. And I have been, he has also told me that in case I get further questions, they will be answered before the procedure. So I am satisfied with this. So this particular paragraph is also mentioned in the new consent which we have prepared, so which can be shared with all of you. So I think COVID specific madam will prepare and share with us, or if you already...
Actually, the COVID consent is no more appropriate because we we just have to give them information, like you said, that the information and the, when to do what. But the COVID consent is now thought quite inappropriate because we really don't know where the COVID is coming from. I mean, it may not be in the hospital. So it's more like an information that you are in a high risk area.
Okay.
So we used to take that COVID consent that we will get, but it is.
Nothing can meet the consent of the COVID format. Okay, the lot of things to be added, and you cannot say it's a fully COVID consent.
Yeah.
The thing is, as Madam said, you have to bring to the notice of the patients and the relatives.
So we will add that particular sentence as long as the pandemic is officially still going on, maybe 1 or 2 years, whatever, that I have been given information regarding this, and yes, voluntarily I come to the high risk area. So that COVID-wise, we'll add that.
And take proper precautions.
Yes. Yeah. COVID appropriate behavior at clinic level, at home level, at hospital level and operation theater level, everything is required, very much required.
So we are taking precautions, but you also take precautions.
That's right, yeah. Second is insurance companies include an indemnity clause and get out of it. How to make them a party? How to make them a party? Oh, that is with the request to the court. First you request to the insurance company. If they deny in writing, then you request the court. Usually the court obliges. Majority of the decisions are against the insurance companies. Majority of the decisions. One more question from Dr. Marathe is, how long is an anesthetist and surgeon responsible for patient's condition after performing a surgery? I think Madam can answer very well because she herself is anesthetist, and anesthetist is always a total control over the surgeon.
As long as you have not handed over this case to any other competent person, you are responsible, especially if you are dealing with a high risk patient who needs further care. If it is a OPD or something which is you're going to discharge the patient, then you are always responsible.
Madam, I think the question was, I don't know who has asked, Dr. Marathi.
After surgery, right?
Yeah,
so if you have sent them home, you have seen that the patient does not need any further care. And on an OPD basis, if you have sent them home, anything happens to them over 24 hours or 48 hours, you are responsible.
Yeah.
The patient gets a post-spinal headache after 3 days, you are responsible.
Yes.
But if it is a high-risk case, you have shifted, to the ICU, and you are handed over to another competent consultant, you cannot be responsible for their further management. And I make it very sure that from now on, the ICU team will take decisions, especially if they're going on ventilator and things like that. We do put in our consultation, but we do not take responsibility in the intensive care.
I agree with you, madam. And I have seen, everybody of us have seen cases in the past that many times there is a hurry that from this place I have to go to the next place, and patients before shifting to a recovery room or outside room, the anesthetist used to leave. So these things have to change. They have changed to a significant extent because just the deep pain you give, deep stimulus, and the patient winces is not adequate to maintain oxygenation and respiration. So this point is important, that if the patient does not require ICU management or recovery room management, in ordinary minor cases, I would say, or daycare procedures, it is the respiration and maintenance of his breathing by himself is more important before the person can leave, or he has to give it in the hands of the next consultant. So it should be made very clear that it is just not a response to the pain stimulus, deep pain, and he insists that is not adequate. He has to maintain his respiration and maintain his oxygenation.
No,
I think if you realize that you are
response to the pain is not at all a recovery side.
You will take adequate precautions.
Yeah. Sumanti Iyer madam is there. Madam, any additions?
No, we are responsible.
Yeah, we need to develop. Sorry, ma'am. You continue. Pratibha, ma'am, please finish. Probably we need to develop criteria for patient shifting out, criteria for patient discharge, parameters, and probably whether we satisfy the parameters. In quite a few hospitals, we have seen some checklists being prepared.
Yes. I think
one side, and the before discharge, the nurse can also check, the doc can also check, and depending upon the parameters as a checklist, if we develop a standard operating procedure, a protocol. And in fact, to be honest, the NABH guidelines 5th edition, all edition, we say post-operative shift from the theater to the recovery, post-operative from the recovery to the ward to ICU. We all have checklists for the various parameters, and depending upon that, we say these are the criteria, physiological, and then it becomes a little safe also. That's
yes. I think that is a system to be implemented in all small hospitals.
There is something which is called an Aldrich score, which works quite well in this.
I think this should be published by the.
This should be published by IMA also. So if you can make a list of common checkpoints, not very complicated, should be simple.
It's not. It's not. It's just a 5-point checklist.
Okay, you can send an article, madam.
I'll send it to you.
Aldrich is very simple and uniformly followed everywhere. Yes, I agree with you, ma'am. Aldrich is followed everywhere.
Very good. Yes. Dr. Shivkumar.
Yeah, most of the mishaps will occur in the post-operative period. As you rightly said, that anesthetists have a tendency to go to some other case, or he will hand over to some junior person to look after that. So these are the critical periods where the mishaps do occur, and we start shifting our responsibility over the surgeon, or surgeon starts shifting responsibility to the anesthetist. So there is a critical period where the fights will go on, the advantage will be taken over by the advocates. So what I say is, once the anesthetist is satisfied that patient is fully recovered, not because of the pinch of pain or whatever it is, but he fits into the particular criteria where anesthetists are recovered, and you have to give it to the competent authority to monitor post-operative. That's what Madam has said it. And when you have a patient is shifted by you, intubated, and you should make a habit that you must accompany the patient till the patient reaches the surgery end. If you leave it to in ambulance to some people, there may be inadvertent extubation where he cannot be intubated, he cannot be mask ventilated. The onus will definitely fall on the anesthesiologist till the patient reaches the tertiary care.
Luckily, sir, here the situation has changed significantly. We have made a very good progress. And previously, the anesthetists were really underpaid. Let's come to the practicality. So that's why they had several small hospitals being attended, and therefore there used to be such a hurry. And luckily now, they are handsomely paid. I mean, nobody can be satisfied anytime. That is another story. They are fairly well paid now. And secondly, the institutes are also many times having 1 day for one anesthetist. So they remain there only. And third, very cunning thing used to happen in small hospitals by intelligent doctors, that they would ask the anesthetist not to leave without having tea and a little breakfast. So that will be natural time the person will wait over there. But anyway, the things have changed for better, and that is a use of law. That is what I would say, that actually these things should be for betterment and not to harass somebody. About one small aspect of another part of the question, how long is the responsibility of the surgeon? So probably I would extend it further, that a surgery has occurred, known complications occur in XYZ amount of time, approximately. And beyond that, how much is his liability? Because ultimately it is the nature's response of the body also. But a claim can be there, even after 1 year, 2 years, 3 years, 4 years. So what I mentioned in my first talk, that if the adhesions occur, and they can occur after several years, then the case can lie, but how the judiciary will look at it? Pratibha or Dr. Sugandhi can throw some light on this.
Basically, when we say about adhesions following a very later, it depends, as you had clearly explained in the act of negligence, whether it is remote or whether it is in the immediate post-operative period. In the immediate post-operative period, we can consider whether it is 6 weeks or 3 months, whatever it is. So if it is not related to the main surgery and it occurs independently later on, then there is hardly anything. But what happens, we should have some some break between the current surgery and the remote complications later on, and that has to be well established on principles of medicine, scientific literature that comes into the aspect. And could I add one more thing about the previous thing about transfer? I heard about something about the transfer out in an ambulance. So yes. Am I right? Yeah, about the ambulance, what I would suggest is that we should see the ambulance is well equipped. Number one, it has got all the monitor, oxygen, this, that. There has to be a checklist checking about the checkpoints. Number two, it has to be accompanied by the concerned personnel, whether it's a doctor, nurse, etc. We can't leave a person going in an ambu with a nurse who's not qualified. there is sufficient judgments, and we should have the proper checklist, and even the biomedical equipment should have the proper checklist, up to date, calibrated, validated, and a proper drug list also kept in the ambulance, and the checking of the drug list, etc., the top up of the drug list after every leg. So the transfer out in the ambulance also, we have to see it is like an extension of the hospital till it reaches the other bigger hospital. So that probably the care also needs to be established. Thank you so much, Dr. Navara.
Thank you, ma'am. Thank you for a very good answer. Yes. Pratibha, you need to add something?
Yes, that's what I said, that complications, early complications, late complications. Early complications, like Madam said, if there is a decent period where the patient has been absolutely normal, I don't know if you can think, but I mean, I will tell you from my own experience that even neurologists seem to say that you've had a spinal anesthesia 10 years ago, so the back pain is because of that. So, there is no end to this, very honestly.
Very sad, yeah. Okay, one more question from the same doctor. How long is an anesthetist surgeon? Okay. Can an anesthetist surgeon be prosecuted if a medico-legal case occurs after operating in a hospital owned by Ayush doctors? Two questions from me. I mean, two answers to this from me. First of all, why did you go there? This medical council prohibits, the regulations prohibit this, but okay, they can own a hospital. Anybody can own a hospital, even non-doctors can own a hospital, so you can go there. But then, can an anesthetist surgeon be prosecuted? Answer is yes, of course, yes. So it's independent. Whatever role they have, they will be always sued.
So also, suppose they have just gone for an emergency, somebody has called them. It all depends on what like you said, what the circumstances of. But if they've been regularly working over there, then I think we can't really protect them too much.
But madam, I just would like to correct my first statement that a hospital can be run by anyone.
Exactly, sir. If I can join in, yeah. If I can join in, yes, the ownership, it can be a non-medical person, it can be a businessman, it can be any. So whether the Ayush person has a role in the concerned,
then he will be also
participating. But if the surgeon, anesthetist, all over the allopath, then why worry? Ownership can be even by a businessman, a person who has not even gone to the school.
The Ayush person will look after this patient afterwards, right?
In that case, yes, it will be there. I know of at least
only administrative role, no. But if the person is going to add any, medication, or he's going to look after afterwards.
Yeah.
Any participation in the management of the case, either before, during, or post surgery, then that is of concern. Then it will be mixopathy, crossopathy.
Or if the doctor is relied upon by these surgeons afterwards, that give me the follow-up report every 12 hours, and something happens, both will be responsible. But mainly, the surgeon will be responsible. Because knowingly he is relying on somebody who is not qualified in the field, is always taken as a negligence. I think all the questions in the question answer box are answered.
Yes, yes.
Anything else the panel would?
Can I ask direct question?
Yeah, please.
Yes.
So whenever we are sending a patient for physician fitness, the physician always writes that this surgery to be done under SA.
Okay.
And this is the point of anesthetic in this situation what to do.
Did you listen to the question? I think this will be very dear and near to any anesthetist and their pride and ego also. The patient is sent for physician's fitness, and he writes on top of it that he is fit for XYZ surgery, and he should be for this particular anesthesia. So, who is the final authority? Why?
Okay.
Yeah, Nauranga, can I ask it?
I would also like to just we are telling the physicians that you give us an evaluation of the patient's condition and the possible perioperative complications. Though they continue to write whatever, but wherever possible, we are trying to change that they will not write fitness. We do not ask for fitness. We say, please kindly evaluate the condition and please inform the patient about perioperative complications related to the disease. And the other thing is, is the patient optimized for for the disease that he is coming to you for?
Yeah.
We are supposed to write.
Yeah. Naurange, actually patient is fit or not fit is a totally a misnomer. Sometimes I've seen the physician writing that patient is fit for spinal anesthesia, epidural anesthesia, general anesthesia. These are all misnomers. And usually anesthetists ask the physicians to optimize the patients if they have the comorbidity conditions, not really for the fitness. So if he says that a patient is fit for so and so, it means that anesthetist is guaranteed for some to certain extent to the outcome. So it is totally the optimization of the patient for so and so proposed surgery, but not necessarily a fitness. There are 1 or 2 landmark judgments in this, whether to give a fitness or not. So it's not necessarily a fitness, it's only the optimization of the patients if need be are required by the anesthetist.
Yes, madam.
Can I add one thing, Naurange, Dr. Naurange?
Yes.
See, the way I look at it, the anesthetist, what they probably examine is what we known as a pre-anesthetic evaluation. And number 2, they also evaluate immediately on the day of surgery prior to giving to anesthesia if there is any change in the condition of the patient. Both are very, very important. And the parameters for the anesthesiologist apparently would be different from that of a general physician or a cardiologist, etc.
Absolutely.
Anesthesiologist parameters is short neck, long neck, malam patti, and easy intubation, difficult intubation, whether it was on a previous medication, so that when they give all this muscle relaxant, whether there'll be any further complication. And whether to refer to physician at all for fitness, probably the way I would look at it, I mean, subject to further comments from Pratibha ma'am and Dr. Shivkumar, is whether it is absolutely essential to refer to them because they have got other illnesses or any other comorbidities for which anything is required. Because it is not a matter of routine, but of course, in some cases it is being referred and the way it is generally working. That is the way I would view it, sir. And
yeah. Definitely, we have a certain gradings. So how exactly we should grade? Yes, grade 1, grade 2, grade 3, grade 4, grade 5, depending upon the various parameters and even the comorbid conditions, elective, emergency, comorbid conditions, airway management, other things. So we risk the particular patient in that particular category. That is the risk assessment is more than sufficient rather than asking for the fitness, whatever it is. I think Pratibha can also throw some light on it.
Yeah, I would like to summarize this all sayings. All are correct and all have given absolutely the correct answer as far as the current era is concerned. Because
Sir, I would just like to add one more thing. Collaboration today is more important than saying. So in case there is any doubt, I pick up the phone and I call the physician and I say that, okay, this is what I am, sending you the patient for. And also that they should take that responsibility post-operatively.
Okay, ma'am. So in short, to your question, I would conclude after listening to all this, and that's my opinion also, that every case should go, Madam Sugandhi Madam, we would request physician's opinion from court's point of view. Why you did not do it? So let there be one referral. If the patient is pending on surgery and anesthesia, let there be one opinion. So there should not be a question why it was not done afterwards. That is number 1. He can give only evaluation about the total body as far as the fitness for anesthesia, type of anesthesia, the controls over anesthesia, what is to be looked after afterwards is a total prerogative of the anesthetist. And as what Madam said, it has to be a collaboration between the two and not a fight between the two. What wording we use, whether it is a use as physician, fitness or evaluation, means the same. So actually what I have seen and faced many times, and coming to these medical legal cases, I learned so many other systems. I'm a pediatrician basically, but then learn more after coming to this medical legal, is that physicians don't, by and large, I'm saying by and large, this is generalization, they don't evaluate the cardiorespiratory reserves from the point of view of anesthesia, which is vitally important for general anesthesia. And that is where there is a friction, that they should not say it's fit for this and fit for that. So they should evaluate the patient from all other angles. I have not come across a single physician who asks the patient for going for fitness that counts 60 in one breath. They don't do that. So that is what the anesthetist does. But one more thing which has come up in just on this last Monday, so not even 7 days have gone, a very interesting case has actually come that in diagnostic centers, Again, a compromise should not be done by anesthetists. That is my sincere opinion, because it's a very risky branch.
Yeah.
Here in diagnostic centers, what happens all across the country, I suppose, that patient is asked, XYZ severe pain, and the patient cannot remain still for MRI, and analgesia is required from the anesthetist, or maybe, I don't know, minor anesthesia relaxation from the anesthetist. The patient is shifted from a hospital to the diagnostic center for MRI, where anesthesia is required. Anesthetist comes, he or she gives short anesthesia, MRI procedure is done, she is about to leave and cardiorespiratory arrest occurs. And the questions have come from the expert body. That you see what happens. Patient has come in an okay state from the hospital up to the diagnostic center for lumbar pain. And the dead body goes back. And the questions have come. Patient has been resuscitated, everything has been done, anesthetist was present. See the questions from the expert committee. Was the patient procedurally evaluated by an anesthetist? Was his ECG and echocardiography done before administering anesthesia? This is any of the audience with me is not knowing, because I have tackled alone, because this requires confidentiality, but I am just posing the legal questions. Was the MRI room having MRI appropriate monitoring machinery? And was there a resuscitation equipment?
Yes.
And now it has come to the anesthetist. So and this has happened in 2 cases in last 15 days. One in a daycare center and one in a diagnostic center. I am speaking from my actual live experience. Now my question is, or say my suggestion is, that anesthetist, even if he or she is working in a diagnostic center, rather casually, it comes from the anesthetist to evaluate the patient and straightway refuse if something is lacking. Is it correct when I say this? Because it is a question's life and death, and no court is going to pardon XYZ anesthetist. That I only go there as for administering short anesthesia cannot be an answer.
Any anesthesia is.
So now I think you are one of the office bearers in Pune or maybe Maharashtra State Anesthesia Department Society. You can forewarn them now that even if it is a short procedure, there has to be a complete evaluation. It cannot be high risk, low risk. Everything is high risk.
Not short anesthesia. Anesthesia is.
There is nothing like short anesthesia.
We have now started doing that. Everybody who has to be given sedation will be admitted in the daycare center. If they need an anesthetist, the anesthetist will do a PAC in the daycare center and send the thing. Because fentanyl is not being issued to anybody who is not admitted. So there are certain drugs which, if we need them, the patient has to be in some kind of an admission. And this usually happens in children. And, they're not evaluated properly. They probably aspirate because they've eaten or had something a few hours before.
This is a lady in the 6th decade of life.
So, but
my point was only to send a forewarning with a guidance from the association level.
Yeah, we will do that.
I think that will be very important, because these cases are bound to come.
Yes. And anesthetists do take them lightly. That is.
Yeah. Jayant, you cannot give anesthesia unless there are resuscitative equipments. Okay, what is the minimum requirement? And also, you should be competent enough to handle such scenario. Unless it is there, definitely, personally, I do not give even a sedation or whatever it is.
Yes, I agree with you, Dr. Kumbara. Even we have the Rashmi Fadnavis, the leading Supreme Court judgment about infrastructure and all that. So.
Because the margin of sedation, patient going for airway obstruction between the sedation, this thing very, very marginal. It's not in our hand. It depends upon the patient to patient. I don't know at what time they go into irreversible brain damage. The best thing, unless you are satisfied about the resuscitative equipments, at least with the minimum bowel apparatus, I am not after to give any kind of sedation, especially in diagnostic centers. So,
Pratibha, you can imagine 2 cases in a city like Pune in 15 days' time. And
Very possible, very possible. So
very
we
sorry.
in an institution had to fight for MRI compatible equipment, because that is 4 times more expensive than.
But then now I think all MRI centers need to buy them now.
Yes. No, the anesthetist has to insist.
Yeah.
So Dr.
Anesthetist has to insist, and if he says that if you don't provide, we cannot give anesthesia.
Dr. English is a very good radiologist, so he will pass on this information through his association. ज्याला आपण जागरूक म्हणतो ना.
Yes, yes.
Very, very alert. What are the winds? Where the winds are flowing?
No, if the anesthetist say no, I can't, then some other anesthetist is willing to do it. So that is our problem, actually.
Okay, thank you so much for the interaction. I'm very happy to see all 235 people still waiting and attending. Thank you very much for making it so lively.
Thank you, sir. Thank you very
I
much.
request our secretary Alka Shirsagar madam for vote of thanks.
And special thanks to Dr. Sugandhi and Dr. Shivkumar because they remained present on our request and joined the panelist forum. Thank you so much.
It was very informative, and thanks for invitation, sir. And it was really nice learning session also. For every webinar, we learned something, and really interactive. And I think this is a purpose we have to be there with our brothers and sisters, and that's the reason. Thank you so much.
Thank you. Madam, vote of thanks.
I'm Dr. Alka Shirsagar giving vote of thanks. I'm thankful to our respected faculties, senior stalwarts for guiding and enlightening our medical legal knowledge today. I'm thankful, special thanks to Dr. Shivkumar Kumbar from Karnataka and Dr. Sugandhi Iyer, who is my classmate, for attending this valuable webinar and guiding us and attending in a panel session. I'm thankful to Dr. Dilip Sarda sir, who is today's MMC observer. I'm also thankful to Mr. Dipen Mehta, DigiShield, and his technical team, Mr. Piyush, for making this webinar smooth. I'm thankful all delegates for registering and attending. There were almost 250 delegates who attended this webinar in large number. So I'm thankful to all IMA staff members for their valuable help in arranging this webinar. So thank you everyone, and with my president's permission, I'll say that this webinar is getting ended. Actually, we don't feel like that we should discuss, and there are so many points in medical legal field. So again, we'll have one more webinar, sir, very shortly. Thank you very much. Thank you very much. Thank you, everyone.
Thank you, and wish everybody a happy Doctor's Day, though belated.
Oh, thank you. Thank you.
Thank you, ma'am.
हे काढायचं का?